When the nation joins hands to fight a common enemy, victory is certain. Though this enemy is an alien contagion, it can be no match for the fervor that unites 1.3 billion citizens. The call by the Honorable Prime Minister also mustered the power and the energy of the nation to surmount the current challenge, bringing into the fray energy conglomerate ONGC. Responding swiftly to the crisis arising from the coronavirus pandemic, ONGC started safety measures very early. Employees were asked to prepare and be technologically ready to face any restriction on movements. Work must go on was the intent. Employees who had been working on the offshore locations and onshore locations offered to continue working with extended duty periods away from their families. Our 24/7 operations and their commitment has ensured uninterrupted supply of oil and gas for the nation. They toil in the fields, adhering to all government guidelines of social distancing and hygiene. Giving additional impetus to these efforts, ONGC contributed 300 crore rupees from their CSR fund, and employees gave 2 days' salary amounting to around 16 crore rupees. But ONGC didn't stop there. We reached out to millions who suffered hardships due to the lockdown. All work centers of ONGC across the country distributed relief supplies to the needy and protective gear to frontline fighters like medical professionals, municipal workers, and security staff.
We at ONGC have always risen to the call of the hour. During this national crisis of COVID-19, we have maintained our offshore and onshore operations round the clock to maintain uninterrupted supply of oil and gas to the nation. While maintaining our operations, we have also ensured full compliance of Government of India as well as WHO guidelines like social distancing, maintaining personal hygiene, work from home, and maintaining operations with skeleton staff to contain this pandemic. I firmly believe together we will overcome this national crisis.
Individually and collectively, these humane acts reflect the selfless, committed, responsible, proactive, and energetic spirit of the nation and also of ONGC, a responsible corporate helping every Indian fight this challenge collectively.
तू ही मेरी एक वजह है, तू ही मेरी ऊर्जा है, तू ही मेरी राहों का नूर। तुझी से तो मैं बड़ा हूँ, तेरे लिए मैं यहाँ हूँ, तुझको मैं जाऊँ कैसे भूल। तू मेरा फ्यूल हो, 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 तू मेरा फ्यूल हो, हो, तुझी से मैं चलता हूँ, तेरे लिए चलता हूँ, तू जो चाहे करेंगे जरूर। जो भी कुछ करूँ मैं तेरे लिए करता हूँ, तुझी से मैं हुआ मशहूर। तू मेरा फ्यूल। टैंक फुल करना।
अरे भाई साहब, लुब्रिकेंट मिलेगा? जी बिल्कुल मिलेगा।
मेरा मैं हूँ तेरी मिट्टी तेरी धूप, तुझसे ही तो घर मेरा, तू ही तो है फर्ज मेरा, तुझसे तो है मेरा गुरूर। तू मेरा
पहले इंडियन, फिर ऑयल। इंडियन ऑयल।
India, one of the largest economies and among the biggest energy consumer nations. Its appetite for energy is growing at pace with its strong growth trajectory. This fast-paced development also means that a responsible nation contributes sustainably to the rise of a healthier, prosperous Indian society. ONGC, since its inception in 1956, has made pioneering endeavors to realize the vision of a proud, self-sufficient, prosperous nation by providing affordable energy. Oil and Natural Gas Commission, constituted by the Government of India to delve into the vast Indian geological landscape, successfully explored the Earth's treasures in arid deserts, dense forests and the deep blue oceans around the Indian peninsula, and scripted India's hydrocarbon saga. The commission, which transformed later into a crown jewel among the country's public sectors. The Maharatna Oil and Natural Gas Corporation continues to lead and set new benchmarks and forges ahead on its mission of energy independence, the main theme of the growth story of India. Breaking the century-old myth at the very early days of its foundation that no significant oil could ever be found in India, today ONGC is successfully producing oil and gas from Mehsana, Cambay, Ankleshwar in Gujarat, Krishna, Godavari and Kaveri basins in the south, to Assam and Tripura in the east. Of course, from Mumbai High, the biggest discovery made in 1974, which brought India prominently on the oil and gas map of the world. And later significant discoveries of Hira, Neelam and Ratna fields in western waters. And the Baseen field discovery in the western offshore, which remains thus far the largest gas field of India. Today we move further and deeper, adopting latest innovations of deep-sea technologies for breaking the challenges of depth, high temperature and high pressure to bring production from new gas discoveries of eastern offshore in Bay of Bengal and in Kutch offshore. Breaking the technological barriers with the adoption of the latest innovations in oil and gas engineering and a focused and motivated talent pool, ONGC continues to be a global leader in the E&P sector and one of the most valued Indian national energy companies. An equal opportunity employer, ONGC is among the most admired organizations of the country and among the best places to work. Every employee is duty-bound and committed to create a healthy, safe and friendly work culture for all. ONGC management takes pride in ensuring that its work environment and facilities are motivationally inspiring for every section of the employees. For ONGC, safety is paramount over any operation. Its safety practices have been globally accepted among the best and have routinely been bringing glorious recognitions. Concerns for protecting the earth and the environment are important factors for all business and operational decisions. Our endeavors and the goals for making alternate energy sources part of our future business are hallmarks of our vision for the next 20 years. In recognition of its role as a responsible corporate leader, ONGC's social outreach initiatives have made a positive, tangible difference to the society it engages with, and its efforts are emulated and quoted for inspiration widely. Aspiring to establish its presence in the entire hydrocarbon value chain, ONGC has today created a niche for itself in not just oil and gas, but refining, LNG, petrochemicals and power. ONGC Videsh Limited, the country's largest international oil and gas company, having widespread global participation in oil and gas business, has been contributing significantly to the revenue growth of ONGC. Almost 7 decades of experience, strong fundamentals, dependable and trained human resource of unparalleled competence has led ONGC to achieve its vision of being a largely self-sufficient Indian conglomerate. Relentlessly marching ahead with breakthroughs that fuel our journey to realize the vision of a prosperous India.
Good evening and a very warm welcome to all speakers and attendees to 8th Global Conclave of AEOHD, OCCUCLAVE 2021. My name is Dr. Angela Sharma. I'm member of Executive Committee AEOHD, and I'll be playing the role of your host today. The theme of this year's conference is Industry Response to COVID-19 Pandemic with New Workplace Occupational Health and Safety Norms. This is a 2-day conference, with today being at virtual platform and tomorrow at Scope Complex, New Delhi. The agenda for today is managing non-COVID morbidities during COVID-19 pandemic. I request Dr. Sandeep Sharma, Secretary of AEOHD, to please welcome all and give an overview of the conclave.
Thank you, Dr. Angela. On behalf of the executive body of AUSD and on behalf of myself, I am very much delighted to invite every one of you for this 2-day conclave of AUSD. Actually, we had been in this COVID pandemic for last almost 1 year, and the evolving situation of COVID-19 is an emerging concern for every one of us. And although we may have unlocked ourselves, but the COVID-19 pandemic is still not over, and the multiple waves of these infections are being seen across the world. So as reported by WHO, also there is an increasing evidence that the mutant strains of SARS-CoV-2 are in circulation in many countries, and all the 3 UK, South African and Brazilian variants, they have been demonstrated increased transmissibility of the infection. In India, since mid-September 2020, there has been a sustained reduction in the number of COVID-19 cases. But in the last few days, we have seen again a surge in the number of new cases, and there is a possibility of new peaks if we are not maintaining our COVID appropriate norms and lowering our guards. So this conference is basically aimed to have an overall view of this COVID situation across the globe, and including how our learned faculties for today, they are managing the comorbidities and how they are managing the non-COVID diseases during this pandemic. So we had been learning from them for last 1 year every Saturday through our DigiConnect webinar platform. But since this is our annual conference, so we thought we should get a overview of the situation through this 2-day conference. So first day will be, as Dr. Angela told, it will be totally focused on how we have managed the non-COVID comorbidities and morbidities during this COVID period. And tomorrow it will be totally focused on COVID again, in which overview of the situation will be there. Then starting from the effects of this virus, how this virus has affected in different places, how it has affected the psychological health, how it has been managed at different workplaces in different organizations, including post-COVID syndrome, then new norms at the workplace. So that whole thing will be deliberated tomorrow by our orators. There will be 7 orations tomorrow. So I welcome you all for this 2-day conference of AUHD, and lot of new things will be learning from our learned speakers today and tomorrow also. And before we start, let me request our President, Dr. Gajendra Kumar sir, to give the inaugural address for today's conference.
It is my privilege to welcome you all of Association of Environmental and Occupational Health Delhi. With change in scenario, that is COVID-19, this year, as Dr. Sandeep has already told, we will be holding in a hybrid mode. Today it will be totally on e-platform, and tomorrow it will be in physical form as well as on e-platform, because the number of participants has to be restricted. The theme of this year conclave is the industry response to COVID-19 pandemic with new workplace occupational health and safety norms. In fact, the new norms are not only at workplace, these are at home, in our social life, our family life, everywhere. Fortunately, we have got a galaxy of experts who will be delivering on different subjects. I also welcome all the speakers of the day to this conclave. So friends, hearty welcome to all the participants, and I wish a conclave a grand success. Thank you very much.
Thank you so much, Dr. Gajendra. So I once again welcome all. And before we start the scientific feast, I'll briefly lay down the structure that we are going to follow today. We have 6 speakers today. Each speaker would be delivering a talk for about 20 minutes, followed by a 10-minute question and answer session. I will be giving a polite reminder 2 minutes before time gets over, and the speaker is requested to conclude their talk within these 2 minutes, please. All attendees are requested to post their question only in the Q&A box. Try to limit your question to only one simple question, please. Only question in Q&A box shall be answered by the speaker. All attendees are requested to keep their mic on mute unless asked by a moderator while asking question. Please use the option of raise your hand to facilitate us. It gives me immense pleasure to introduce our first speaker, Dr. Colonel Vijay Langer. He is visiting consultant plastic surgery, Sitaram Bharti Institute of Science and Research, New Delhi. He'll be talking about management of burns and trauma injuries. Dr. Langer is a senior consultant plastic surgeon working as a visiting consultant in plastic surgery in multiple prominent hospitals in Delhi. Dr. Langer had a distinguished service in Indian Armed Forces Medical Services for 28 years. Has amassed a wealth of clinical experience of over 13 years in plastic surgery. He was a professor, teacher, and examiner for a National Board of Examinations at Army Hospital. Before that, he was a professor and at the Armed Forces Medical College, Pune, which has been adjudged the 3rd best medical school in India. The high points of his academic pursuits have been passing MCH plastic surgery in 1st division, and then being awarded the gold medal in DNB, examination in plastic surgery, in the year 2006. So I welcome Dr. Vijay Langer, please. Sir, the floor is yours.
Thank you very much, ma'am. I hope I'm audible and the video, the presentation is seen.
Perfect.
Thank you very much, ma'am. Thanks very much, the organizers, and I think we've got a larger audience today than the last time that I delivered a bit of this talk. And thanks once again, and thank you very much for special thanks to Mr. Vikrant from Convotech, who's helped me get on the podium. So without wasting time, I thought the presentation was worth 35 to 40 minutes, but it's been halved, and therefore I must, as usual, rush through a lot of these slides. So the stress on today's topic for me would be the general area of trauma reconstruction, but with special emphasis on the burn wound injuries, which we've had some exceptional results in the army, especially at Army Hospital R&R in New Delhi. So very quickly, going as per the ATLS philosophy, the patient, injured patient, which the industry definitely faces, has to do with primary survey, what is killing the patient, to treat that, secondary survey to proceed to identify all other injuries, and definitive care, that is the tertiary survey. Again, send the patient very fast to the neighboring hospital, scoop and run policy, which works well in the Indian setting. And obviously the golden hour, what the golden hour is for a hospital setting, the platinum 10 minutes are for pre-hospital phase. So therefore the patient has to be rushed immediately to the hospital. The patient on admission or on reception at the A&E is triaged with red, yellow, green, and black. I will not go into details. Primary survey done by A, B, C, D, and E, especially to prevent head injury or maintain the airway with cervical spine protection, allow breathing, facilitate breathing, circulation with either peripheral lines or central venous catheter to assess the disability or neurologic status and undress the patient and check for environmental control. Indeed, hypothermia has to be tackled because a lot of these patients die of acidosis and the complications due to hypothermia. What needs to be done, obviously, is to stop obvious bleeding, elevate legs, IV fluids, and transport to hospital. Like, for example, this sort of a wound which has to be bandaged, and or preferably put the tourniquets placed, and we can keep the tourniquets on for about 40 to 45 minutes, and then release for about 10 to 15 minutes and accept the blood loss that occurs during that time. Meanwhile, the patient should be immediately evacuated to the hospital. Splinting of the fractures will reduce pain and also reduce bleeding. Any penetrating object in the field should not preferably be removed, because otherwise it might result in torrential hemorrhage and loss of limb or life. And this is a similar injury, such as the industry. We used to see a lot of these injuries in war time scenario. And indeed, this patient who has chest trauma and abdominal trauma will require multiple teams operating on him and multidisciplinary support. A quick recap of what the burn wounds that we face. Just a quick recap of what the superficial burn wounds are. So to the top left and right are the superficial burn wounds, which will heal on their own without without any excision or without any removal of the dead tissue. Whereas the deep wounds, which is in the center bottom of the screen, will not heal on their own and may require surgical help. So there are four types of 4 degrees of burns: first, second degree superficial, second degree deep, and third degree. Mainly, the first one is usually not seen in clinical practice. It's usually a sunburn, and it will heal miraculously by 2 to 3 days. Second degree superficial will also heal by 10 to 14 days without any problems, but it has a moist look, and the patient looks rather moist compared to a second degree deep or a third degree wound, which has a drier look. Indeed, the most important aspect, or most important clinical differentiation is when the clinician places a thumb or an index finger on top of the wound and it blanches. It is a second degree superficial wound. Second degree deep wound does not blanch on pressure. And third degree has a parchment like a very dry, white or charred look with no blanching. That is the second degree superficial burn wound, and definitely it heals, like such as this patient, it heals without scarring and any complications or any hypertrophic scarring. Yeah, and that's the second degree deep wound. So the blisters are present, but they're very rather smaller, but the patient has a very dry look, and these will require excision for better survival. Third degree, which is or to the left is the acid burn, and to the right is an electric burn injury, which are commonly seen in the industry also. This is again another patient with electric burn, and this patient had to be debrided. And after debridement, we can see the spinous processes in the lower back. That means that is the extent of the burns. Finally, we lost this patient because of massive muscle damage. So why do we need to know this differentiation? Because superficial burn wounds will heal on their own if they are not allowed to get infected, and deep wounds will need to be excised and covered with skin or skin substitutes. Indeed, early burn wound excision, which we are proponents of, has myriad advantages, such as shorter hospital stay, lesser fibrosis, lesser contractures, better scars, lesser disfigurement, and better survival. That's our smallest baby patient, the youngest baby patient, a 10-month-old baby with 15% scals, and we excised 12%. The hospital stay was just about 10 days or so. The healed donor area was from the back, which is seen on the right of the screen. A patient with 60% deep flame burns, which, as you can imagine, in most centers would not survive. But here, this patient not only survived, he carried on in the army, and the total hospital stay was 60 days. So that's him before surgery, during surgery. That's the early post-op, the hand function, which is fantastic. The late post follow-up, and you notice that there are hardly any hypertrophic scars, despite the patient having deep burn wounds. A father-son duo operated in May 2015 by us. The 43-year-old father had 6% flame burns over the hands, and that's him after surgery. But the son had 50% flame burns with inhalation injury. That inhalation injury definitely increases the mortality by 20% or so. So you can imagine the extent of the threat to life is all that much more. 45% were deep, and he was excised, and all of them covered. The raw areas in the body were almost 90%, because you can imagine 45% of the burn wounds were covered with 40% skin graft taken from 40% total body surface area. So almost the whole body was covered with wounds, and that's him before surgery. That's him during surgery. the skin grafts have been being placed. That's post-operative day 6. And look at how he has responded. On day 21, he's almost ready to be discharged. And he's up and about and he's out of sepsis. And look at the wounds on the face, which have healed miraculously. That's the father-son duo ready for discharge. Special mention during hand burns. In hand burns, the top row shows how the patients can be absolutely crippled for life if they are not operated with early burn wound excision and cutting away the dead skin and placing a skin graft. Here in the bottom row is a patient with good hand function after early burn wound excision and skin grafting. We had the honor of publishing our work in a journal in the year before last, in 2019. This is indeed an ode to the Indian soldier. The Convatec has come up with a fantastic dressing, which is called an Aquacell AG burn dressing, which is very good for second degree superficial or superficial burn wounds of the hands. And these gloves can be maintained for, they say, 21 days, but in our tropical climate, we keep them on for about 7 to 10 days. The other wound dressings which they promote are the Aquacell AG surgical dressings, which they have also seen to reduce the surgical site infection as well as reduce the infection in burn wounds. So a quick word with the limb injuries. We do not forget to treat the patient rather than concentrate on the limb alone, and consider and manage other serious injuries too. The key to success in limb injuries is to debride, and preserve. So indeed, there should be a very high index or high threshold for amputation. Having said that, if the patient is hemodynamically unstable and there is a single surgeon anesthetist combination, then with multiple injuries, let's say to the injuries to the limbs as well as the thoracoabdominal trauma and head injuries, etc., it is worthwhile to try and save the life rather than the limb. So in that case, the limb might have to be amputated. And that's why the role of referring or transferring these patients at lightning speed to a tertiary referral center where multiple teams can take care of these patients. The order of priority of limb injuries is first skeletal stability, then repair of tendon, nerve, and joint, primary or delayed primary coverage. But indeed, the important thing is to cover the wounds by 3 to 5 days. Again, this is very, very important, because if we achieve primary healing, then we achieve better function. And definitely the patient does not go into sepsis. So most physicians, a lot of people in the audience would feel that maybe this limb should not be saved. If it is only isolated injury, it definitely should be. And this is a high technical surgery, multiple digit replantation, where not only the bones are stuck together, but also the arteries, veins, nerves, tendons, and this operation took about 17 hours to take care of the 3 fingers. And that's her writing. That's another young child with a partial thumb amputation with a good hand function. That is the complete amputation of the hand from the wrist level. And that's the patient showing good function. So how are the amputated parts to be transported? Not surrounded by ice, not submerged in water, but should be placed in a plastic bag. The plastic bag should be placed in a bag of ice or with the ice around it, and no direct contact with the ice or water. That's a common injury which happens, glass cut injury, giving rise to what is called as a spaghetti wrist. And that shows multiple tendons and multiple arteries and nerves which have been repaired. So one does not feel that usually the glass will not cause so much problems, but it invariably does. It cuts and cuts brutally like a knife. That's how the patient of ours, a brave patient who had a mind blast injury, a thigh flap was given for full recovery. That's the importance of skeletal stabilization. You can see the limb is absolutely flail post injury, and that's him after the stabilization. Another patient with an exposed ankle and in immediate skeletal stabilization and a flap cover in the bottom right photograph. That's another patient with the lower limb trauma and a free gracilis. So the gracilis is a muscle from the medial aspect of the thigh, which is taken, and free flap is something which takes care of small sutures to anastomose artery and vein with sutures which are thinner than our hair strands. So to salvage or primarily amputate is a problem, and there are many factors, many scores which have been advocated. It's best left to the treating surgical team and how the transport pans out. But we must remember in assessment that limb saving must never become a triumph of technique over reason. We should try to aim early skin cover in these patients because it promotes wound healing, better wound healing, promotes prevents fibrosis and accelerates rehabilitation, reduces hospitalization time and saves cost and time away from work. So the wound after surgical debridement should look like this. It should look absolutely neat, and there should be no devitalized skin edges, no grit, no untidy look in the wound. And over the limbs, we must try and use tourniquet at all times. Another patient with a similar injury, a fasciocutaneous flap, which has been placed. That's the reconstruction. For the upper leg defect with a hollow over the tibia, a muscle flap from the back of the leg, back of the calf. That's that's another patient with a heel injury, a non-weight-bearing heel injury, and a perforator flap or a flap which is taken from the neighboring leg has been used to cover the defect. A patient with an amputation of the other limb with a free latissimus dorsi, that is the muscle from the back which has been taken, and the patient is absolutely fine. Another patient with the free gracilis muscle flap, and this patient again had through tibia amputation on the right side. For the left, he was given a gracilis flap, and there he is rehabilitated.
So you are in last 2 minutes.
Yes, ma'am. A quick blast injury face, and that's the result which we could maintain, could get in to effect early burn wound, early wound treatment. And to recapitulate, acute wound will require coverage by 3 to 5 days, and we have to go very aggressive on debridement. Indeed, we had the honor to pen down my thoughts on the article on the subject with management of major limb injuries. That was a review article. To conclude, we go as per the ATLS philosophy, indeed ABCDE, to treat the patient, not the body part. Technology is not superior to common sense. We should remember that. Aggressive debridement is the key to success in outcome, and even so in deep burns. Early burn wound excision is the key to survival in deep burns. Early coverage by 3 to 5 days gives the best result in these traumatic injuries. And newer dressings with hydrofiber help control infection in wounds. These are my particulars. I'll be glad to take any questions and answers, as well as any personal contact. And I'm active on Facebook as well as Instagram. Thank you very much for your patient hearing.
All right. Thank you so much, sir, for a wonderful talk. And really, I did not want that it should end because it was so knowledgeable. But thank you so much for finishing it bang on time. Really appreciate.
Thank you very much.
I have a few questions, if you can please help me. And it is particularly for the transportation. Like at the injury site, how best we can manage before actually the patient arrives at the hospital. Say, for example, there is an amputation, a finger has been cut. So how much time do we have to put it back in place? How fast should they drive?
Right. Very, very good question. Yeah. So, so if the muscle, this is where we are talking about the limbs, obviously. So if the muscle is there, that means if it is in the arm, forearm, or the thigh or the leg, then the muscle has very short ischemia. So within 2 hours, the surgery should ideally start. However, in a finger, in Siberia, they have successfully reimplanted by even 96 hours, 90 to 96 hours, because of the cold, and there is no muscle here. So in temperate climates, definitely it will be of value to, they can even do it in 10 to 12 hours, maybe 24 hours. In Indian setting, in the tropical climate, I think as fast as possible, but a finger possibly by 4 to 6 hours.
Right, so thank you so much. And similar question in terms of application of tourniquet. So if we have applied tourniquet, so how much time window do we have so that the limb cannot be, doesn't need to be sacrificed?
Again, very good question. So if it is in a pre-hospital setting, obviously the tourniquet pressure cannot be controlled. So 45 minutes is a safe limit, as I said, 45 minutes, after which dressing, and if the patient still hasn't reached the hospital by that time, then a tight bandage can be placed and the blood loss should be accepted for 10 to 15 minutes, after which the tourniquet can be reapplied for another 45 minutes. In the hospital setting, for the upper limb, it is 100 millimeters of mercury above the systolic blood pressure. That is the pressure. And for lower limbs, it is usually double the systolic pressure. This can be continued for 2 hours. We release the tourniquet after 2 hours for 15 minutes and then can reapply for another 2 hours.
Right. So thank you so much. So do you have any other question for this wonderful topic? So we have a question here for you at Q&A. What medium can be used for transportation of the part?
So yes, thank you, Dr. Archana. I said that so do not worry about sterility. Just drop the part into a plastic bag and surround the plastic bag with ice. There should be no direct contact with water. There should be no direct contact with ice of the amputated part. Do not worry about sterility, because that is always a concern. And people say, no, there was a lot of grease and that's why I couldn't send it, or I was trying to clean it up and so on. The plastic surgeon has to clean it. The plastic surgeon will clean it. So there's no problem in that. Thanks, Dr. Rajesh. Material used for burn case dressing. So I presume you are talking about, should I type the answer? It says type the answer or answer.
Okay, sir, you can speak.
Okay. So the for the second degree superficial burn wound, a very good question, but second degree superficial burn wound, Silver X, earlier silver sulfatazine was the best agent. Any guesses why it's gone out of out of vogue, probably because it doesn't have too much of a margin. So it's just disappeared from the Indian market. And when we were doing our MBBS and as young doctors, not even surgeons, silver sulfatizine was very freely available and it was very good. But now it's been replaced by Silver X. So silver nitrate. In fact, I didn't have time, but I just saw a baby yesterday, 5 year, 6 year old, whom I healed. I didn't heal, but God helped me heal the wounds. The wounds healed in 3 days of Silver X application. A thick layer of Silver X with for superficial wounds. Remember, with a bactigras or a chlorhexidine gauze, on top of which there is a thick layer of Silver X. Ideally, a 3 centimeter layer. 3 centimeter is impossible because 3 centimeter would be 2 finger breadth width. That is not possible usually, but you just take a lot of Silver X and throw it on the wound, and then dress it, and maybe change the dressing after 2 days. Ideally, bookish knowledge, twice daily or maybe once daily change of dressing. I'll tell you the problem with this change of dressing is, if it is done on a daily basis or a twice daily basis, then whatever healing has occurred, you will take off the healed edge when you do the dressing. So the idea is to try and postpone the dressing. But this is, remember, only in second degree superficial burn wounds. Nerve injury time for rejoining. Good question, Dr. Ganesh. The nerves have to be joined ideally as fast as possible within 24 hours, maximum 72 hours. So if the patient cannot reach the plastic surgeon the same day, there is no problem. You close the wound, ensure that there is no bleeding. You close the wound and you refer and transfer to a plastic surgery center, preferably with a splint. So supposing if there is a cut on the volar aspect of the wrist and it has cut the median nerve and the ulnar nerve, then you close the wound. Do not try any heroic surgery. Just place a splint like that so that it does not prevents the wrist from movement, and therefore the retraction of the nerve ends, and sent to the plastic surgeon, because these sutures will have to be taken by the plastic surgeon under magnification, under loop magnification.
Sir, since we have another 2 minutes and I would really want to make most of it because it's such an interesting topic. We know that impaled objects should not be removed, but
Yes.
like you had the slide as well. In case it is a glass, then what do you recommend?
Yeah, so once again, ma'am, a good question once again. So if it is in the pre-hospital setting, do not remove, because glass will also do the same thing. If it's a glass shard which is going here, if you remove it, the radial artery, which might have been punctured and is stabilized with the through and through movement of the glass, will start profusely bleeding, and then there's panic. A lot of panic, remember, happens because there is a lot of torrential hemorrhage. If there is torrential hemorrhage, the response to panic or to prevent panic, one must apply a tourniquet. Even a BP cuff, a blood pressure cuff, will be fine.
Right. Thank you so much. And really, the last question, I promise you that. Is the management of electric burn different as compared to any other burn?
Oh yes, oh, yes.
In
Electric burn, yes. I haven't dealt that with that in detail, but Parkland formula or the IV fluids is 4 into percentage of burns into the surface area, and basically this has to be divided. It has to be pushed in the first 8 hours. In electric burns, it is usually to ensure that the urine output in adults on a general scale should be about 100 ml per hour. That means the fluid requirement might be 1.5 to 2 times the usual requirement of the normal thermal burns. That is one. Second, the muscle damage is tremendous in electric burn injury, especially in high voltage electric burn and arc injuries. So basically, if something like a bullet wound, a rifle wound, wound of entry is small and the wound of exit is large. So it gives a ballistic or a blast effect. The same thing happens in electric burns, and therefore these patients have to undergo extensive debridement. And we've had some really macabre incidents in the army where we've lost patients to multiple amputations, and still we continue to lose limbs after limbs in the same patient, and they still continue to deteriorate.
Right, sir. Thank you so much. Really appreciate for all the valuable knowledge that you have given today. Thanks a lot.
Thank you very much. So kindly.
I take the privilege to invite our next speaker now, Dr. Meet Kumar. He's Consultant Institute of Blood Disorders and Bone Marrow Transplant, Fortis Memorial Research Institute, Gurugram. He'll be talking about changing outcomes in severe aplastic anemia. Dr. Meet Kumar is practicing hematology and BMT for last 10 years. He has successfully done over 350 bone marrow transplants. He has completed his MBBS and MD from Jamnagar, Gujarat, and his DM hematology from NRS Medical College, Kolkata. He has done his fellowship in bone marrow transplant from Tata Medical Center and specialist training in BMT and CAR cell therapy, King's College, London. He has also worked in prestigious institutes like Sir Gangaram Hospital, Delhi, SGPGI, Lucknow, BLK, Delhi, King's College, London. He has more than 20 research publications in national and international journals of repute. I welcome Dr. Meet Kumar.
Good afternoon, everyone. Am I audible?
Yes, sir.
Thank you, Dr. Angela, and the entire team for organizing this wonderful conceptual thing to make people aware on occupational health hazards. So this is just a wonderful company of people to have this afternoon. That is the first thing I'd like to say. And at the same time, the concept is such a wonderful concept that can raise awareness amongst the occupational health hazard people who are exposed to chemicals in day out, who are exposed to radiation day in, day out, and very specifically chosen topics for this meeting that focus on these occupational health hazards. So the role of pharma cannot be neglected. That has to be encouraged more and more to spread awareness on these occupational health issues. So thanks a lot to the pharma involved. And with this, I'll start the topic for today's discussion from hematology side on aplastic anemia. So we all know what is aplastic anemia who are dealing with occupational health hazards. So in the next coming session or so, we will be discussing about what is aplastic anemia, what is its current treatment, in the sense what is the medical treatment and what is the curative treatment, the surgical, non-surgical treatment. All those aspects we'll be covering in the next 15-20 minutes. So next slide, please. Next slide. Next slide. Yeah. So the previous one. So aplastic anemia is basically a disease wherein the bone marrow stops to function. So bone marrow is the place, or it's a factory, as we are all dealing about occupational health hazards in factories. So bone marrow is the factory of the production of blood. So whatever blood is circulating in our body, be it be hemoglobin, be it be platelets, be it be WBCs, or that is called as total leukocyte count, is produced in the bone marrow, and from there on it reaches the market, that is the circulating blood. So when this factory goes haywire, when the company does not produce normally, the factory does not produce normally, it can result in cytopenias in medical terms. That essentially means that the patient's hemoglobin is low, patient's WBC count is low, or platelet counts are low, or a combination of all these is present. So this means that the patient is not able to produce one of these components, essential components of the blood. So what is important for us to understand is how frequent or how common is this? So do we need to worry about this thing? Do we need to like, how do we confirm this problem? And what is the way forward to treat this? So in this term, it is interesting to say that we are the maybe chemical industry of the world, and that is one of the reasons why we have such a huge load of people who have this type of disease called aplastic anemia. It is surprising to note that maybe in the West, the incidence of aplastic anemia is only 2 cases per million per year, while in India, the ratio is almost 7 times, 6.8 million per year population. So that says that we are 7 times more exposed to maybe chemicals or other unknown factors, but for sure we know that the incidence of aplastic in our population is quite high. So India is distinct from the rest of the world in the sense aplastic anemia is more common. It affects commonly in both genders, and it can affect at any age. So there is data that I've not shown here that people in India or patients with aplastic in India present at an earlier age. So that also is a known fact. So there are things that need to be understood in terms of identifying and epidemiologically understanding the patients who suffer from aplastic anemia in India. Next slide, please. So this is the typical presentation how a patient of aplastic anemia can present in a clinic, outpatient clinic. So one of the symptoms of various types of cytopenias can be the clinical presentation for aplastic anemia. If hemoglobin is low, the patient can present with weakness, fatigability, exertional dyspnea, or having bleeding from any site if the platelets are low. So bleeding can be from any site, starting from skin, oral cavity, that is gums, rectal bleeding, that is bleeding in the stools. So all these features can be present. More subtler bleedings can happen in internal organs, that includes the abdomen, the chest, or the brain, which are more sinister than the superficial bleeding. When the TLC is low, we all know WBC counts, when they are low, the patients are predisposed to more infections. The patients can sometimes present with various types of fever or combined with fever and bleeding. So these are the common presentations: hemoglobin low, platelet low, TLC low. These are the common presentations with which the patients of aplastic anemia usually present in the OPD. So there is a very important thing to understand here. The severity of the disease depends on the severity of cytopenias that we will be discussing in the subsequent slides. Next slide, please. So this is what I was talking about, how severe a patient is having aplastic anemia. That depends on how bad the patient's cytopenias are. So if the patient has essentially a neutrophil count, so that is called as absolute neutrophil count of more than 500, that means that the patient is having sort of non-severe aplastic anemia. If the patient's neutrophil count is around 200 to 500, that means patient is having severe aplastic anemia. And if it is less than 200, that means the patient is having severe or very severe type of aplastic anemia. So it is important to understand, more severe the type of aplastic anemia, the lesser the chances of treatment and successful treatment with medical management. Next slide, please. So this is the typical treatment algorithm that is conventionally used for patients who are suffering from aplastic anemia. Once the patient is diagnosed, the treatment will depend either on the age of the patient, and secondly on the availability of a donor for a stem cell transplant. So one of the treatments is medical treatment, the other treatment is a bone marrow transplant. So what we need to understand here is what is the age and availability of the donor. For younger patients who are less than 35 years of age, or maybe now people have started saying that if the patient is less than 50 years of age, the best treatment, if there is a full matched, that is HLA matched sibling donor available, the best treatment outcome is by undergoing a stem cell transplant upfront. So today I diagnose a patient based on his bone marrow test. He is having bone marrow cellularity of less than 20%. His neutrophil count is less than 500. I get an HLA typing done for him and his brother or sister. They are full match. In the next week, we will admit the patient for a bone marrow transplant. And the success rates, interestingly, for such a procedure in a patient of aplastic anemia in today's world, because of the development of such good medicines, is now more than 80%. So at our center, we have done close to, I'll say, 150 transplants for aplastic anemia, and our data stands at 85-86% of long-term success. So recently we had a patient, today we have a patient getting discharged. Yesterday we discharged one patient, and that patient came to us with a bad cellulitis involving the face. I don't have his pictures at present. So she had a bad cellulitis involving left side of the face. We started the patient on antibiotics, did the workup. The workup revealed she is having aplastic anemia. His brother was a complete full match HLA typing based, low resolution. The patient proceeded with a matched sibling donor transplant, and today she is day 21. So she engrafted the donor cells, engrafted in the patient's body at around day 14 for neutrophils and day 17 for platelets. And his cellulitis has resolved. Her aplastic anemia is cured, and she is getting discharged today. Yesterday she got discharged with a neutrophil count of 3,000. So that's the beauty of the patients who require stem cell transplant for aplastic anemia, and the success rates are really, really very good. So those patients who do not, so this is a patient success story of a patient who had a full match donor available. What if there is a no full match donor available for such a patient, and this patient comes with bad infections or otherwise? So the treatment options for such patients usually are to go for immunosuppressive therapy. The immunosuppressive therapy means the use of a combination or cocktail of drugs that are called ATG, anti-thymocyte globulin, in combination with one of the thrombopoietin analogs. So that is eltrombopag, and in addition to that, a oral immunosuppressant drug called cyclosporin. So with all the three combination, the success rate today, as we'll discuss subsequently, has crossed almost 75-80%. So with the development, so that's the beauty of science. The development of science has given us so much tools that we can use in clinical practice, that the success rates are going to touch the roof. So for such patients, as we said, the treatment for patients who are fit for transplant, who are younger, and who have a matched sibling donor, transplant is the best treatment. Of course, cost is an issue, but yes, at Fortis Hospital, Gurgaon, it's good to us that the management to us is supportive, and we can do some good charity work for patients who require transplant or urgent transplant for such patients, and we can do away with transplants at much lesser cost as compared to corporate world. So that's the important thing. The second thing, for those patients who are not transplant eligible, who need a treatment, they can also be well treated with the current medical management that involves horse anti-thymocyte globulin, cyclosporin, and eltrombopag. The combination of three results in good outcomes, almost 75-80%. Next slide, please. So that's what happens if the patient relapses after the initial treatment. So initial treatment, the patient received ATG. So recently we have a patient who came from Bihar. He was treated initially in AIIMS Patna, diagnosed to have aplastic anemia in AIIMS Patna, subsequently referred to Fortis Gurgaon. That patient was extensively tried. He was only 30 years old. He was we expected to find a suitably matched donor for the patient, but unfortunately there was no full match donor. So that patient received anti-thymocyte globulin, eltrombopag, and cyclosporin, and now he's almost 3.5-4 months post his treatment. So he's continuing cyclosporin and ribolate, and he's off ATG for last 3.5 months, and his counts have now become transfusion independent. So he's not requiring any more transfusion. So that's the beauty. So now what happens if down the line, 3 months later, this patient relapses? Then what is the option for us? Then the option for us is to go for various type of non-matched sibling donor transplants. And one of the best treatment for that is now in today's 2021 is to go for either a matched unrelated donor transplant or a haploidentical transplant. So if that is also not possible because of various either logistic issues or because of toxicity issues, maybe the next option for that patient is to go for something called as rapid ATG. So ATG is an injection that is prepared from serum of animals. The most common preparation that we commonly use in practice is from horse. But if the patient fails horse ATG based treatment, the next line of treatment for such patient is to go for alternative donor transplants, alternative donor transplant not possible, then to go for a rabbit ATG based treatment. So the second animal from which, or second equine from which the ATG can be harvested in, derived, is from rabbit sera. Patient fails such second line of treatment with rabbit ATG based therapy, then the alternative options include use of alemtuzumab, trial of androgens, or experimental therapies. Even arsenic has been tried in such patients and has shown to be of some utility in some patients. Next slide, please. So that's what the progress of aplastic anemia in the era for the last 30 decades or so has been. So the sea change happened when it was identified by the NIH group in Bethesda that aplastic anemia essentially is an autoimmune disorder. So they did a beautiful study that showed that the patients who received cyclosporin accidentally, patients of aplastic anemia who accidentally received cyclosporin, those patients somehow seem to be responding to this treatment. So then it was hypothesized maybe it's autoimmune mediated, and the whole lot of battery of tests and experiments were conducted, especially at NIH, the Neil Young group, and they concluded, probably world across, the same studies were recapitulated across Europe, and that we derived to the conclusion that aplastic anemia is usually autoimmune derived. So based on this came the role of ATG that was first used in around 1985 or 1987 for patients with aplastic anemia, and thereon started the success story for the success of treatment of aplastic anemia with medical management. So that means that with ATG, so we are saying that L-Trombopag we are able to use now for the last couple of years only, but way back few decades back when Revolade was not available, at that time patients used to be treated with ATG and cyclosporin. The response rates to that was around in the range of 60%. But with the availability of the L-Trombopag, and especially the NEJM paper that got published in 2011 that incorporated, not 2014, and that incorporated L-Trombopag to the treatment regimen for ATG cyclosporin combination, the response rates have now been around 80%. So that's the 75 to 80%. That's the beauty of it. Next slide, please. So this is the combination regimens that have been used across the globe, and that's the responses. So this is what I was talking about. And the highest response that is around 77%. So that's the range to which the patients will respond. Next slide, please. Next slide. Yeah, so that's the thing that we were discussing about. Response rates to IST is 70%. Next slide, please. Yeah, so again, I think we have already discussed this slide. We'll go to the next one. So the important thing that we have to understand here is patients with occupational health related aplastic anemia, they do tend to respond to ATG, but important thing is ATG based therapy. The important thing is the time taken to respond to this medical treatment usually is 3 to 6 months. So we have given the ATG injections today, and we expect that after 1 month the patient's CBC will be normal. That is highly unlikely thing to happen. So it takes around minimum of 3 months. So usually we say that if the patient is not responding by 6 months, and by 6 months the patient is transfusion dependent, that means the ATG has failed or the ATG based treatment has failed. Only then the second line treatment needs to be brought into the picture. Next slide, please. So the other important thing is, what is the frequency with which ATG will fail? As we discussed, the response rates with ATG or cyclosporin is around 60-70%. With Revolade combination is around 80%. So remaining 20-30% may have a relapse rates at various time points. Next slide, please. So how do we assess the responses? So this is what I was mentioning previously. So there are two categories in which we can classify the response to ATG based therapy. And the important thing in that is, one is complete response. That means the patient's the patient's CBC previously was whatever abnormal because of the aplastic anemia, and beyond 3 to 6 months of therapy with ATG based treatment, treatment, the responses now have been hemoglobin is more than 10, WBC count is, or the neutrophil count is more than 1500, and the platelets have become more than 1 lakh. Interestingly, but unfortunately, this happens maybe in probably 20 to 30% of the patients. So that means whatever patients do respond, majority of them will have a partial response. So what is partial response? The partial response means that the patient does not have a normal CBC, normal complete blood count, but the patient does not require any more blood transfusions or platelet transfusions. So he's free of and is independent of transfusion requirement, although his CBC is not back to normal before his aplastic anemia was diagnosed. Next slide, please. So this is the beautiful slide that what are the unmet needs in the treatment of aplastic anemia with the medical management, ATG-based treatment that we have to understand today. So a 1/3 to 1/4 patients will not respond. So 25 to 35% patients will not respond to ATG. That's a hard fact, and we have to understand that. 40% of these unresponsive patients will die within 5 years of diagnosis because of various reasons. So most common of which is infections. So the aplastic anemia major killer is infection. We have to protect the infections, and we do whatever best to protect the patients from infections. Infection is the number one killer for patients with aplastic anemia. The third problem that is not mentioned here is the patients who receive ATG-based combination therapies in the long run have a probability to develop clonal evolution. So what does that mean? The patients can develop newer chromosomal abnormalities, maybe 1 year, 2 year, 3 year down the line, and that may predispose the patients to develop a second malignancy. So the chances of developing a malignancy after the initial ATG-based treatment is in the range of 2 to 4%. So these are the major issues that have not been answered as of day-to-day medical science. Maybe transplant is a better option. That is why people these issues are not there with using transplant based, but the transplant itself has its own limitations that we have discussed in terms of time, cost, commitments, logistics, all these issues. Next slide, please. So this is the important study. So why do we use Revolade L-Thrombopag in the first line management of aplastic anemia? We have already discussed this. Probably 70% versus 80% makes difference, and that is why we add L-Thrombopag now as the standard of care first line treatment for patients with aplastic anemia. Next slide. So there is a bit of science that can be discussed here. So that science says that the reason why patients fail aplastic anemia treatment with ATG-based therapy is that the stem cell numbers in such patients are low. So the curve to the left says that if the stem cell numbers are lower the number of stem cells, so that can be corroborated with the extent of cytopenias as we were discussing previously. So more significant the cytopenias, probably lesser the number of stem cells that are functional inside the bone marrow of that patient, and hence less likelihood that the patient will respond to ATG-based therapy or ATG cyclosporin-based therapy. There comes the reference and the science that addition of L-Thrombopag, that is a stem cell stimulant, the addition of such stem cell stimulant can work effectively for us, for our favor, and help us increase the number of stem cells and thereby improve our responses. So that's the science behind it. That's the hypothesis behind it. And that was very well proven in this study. Next slide, please. Again, the next slide, please. The next slide. So this is the one cartoon that I wanted to show. So probability of failure is more if the stem cell numbers are low. What L-Thrombopag therapy does to this is increase the number of stem cells by the mechanism of its action. So L-Thrombopag is basically TPO agonist, thrombopoietin agonist. So this thrombopoietin, we conventionally think that they are present on platelets and megakaryocytes. But interestingly, this TPO the TPO molecule receptor is present extensively on the stem cells as well. So when we give L-Thrombopag, it definitely helps us increase in platelet megakaryocytes. But at the same time, it has been shown scientifically to increase the number of stem cells as well. So that would mean that if the stem cell numbers are increasing by addition of L-Thrombopag to cyclosporin ATG combination, the responses rates should increase logically, and that has been shown scientifically and data-wise. So the rationale for incorporating L-Thrombopag in the frontline treatment. Next slide, please. So there is good evidence, science as well as data. The next slide. Next slide. So that's the NIH study. So NIH is the forerunner, front runner of providing the scientific advancements, both in terms of pathobiogenesis as well as advances in treatment for aplastic anemia. The Nelian group has been the pioneer the world across, and we have been fortunate enough to be taught by him at certain point of time. And the science says the L-Thrombopag as first-line treatment does work effectively for such patients. Next slide, please. So that's a paper that I was mentioning about. This was published in 2014. So that was the paper I was mentioning about previously. Next slide. Next slide. Next slide. So L-Thrombopag should be used. How it should be used? What are the side effects? What dose should be used? When it should be interrupted? These are all questions that come to our mind when we are using such drugs. ATG cyclosporin we have used enough in the past. We are quite well versed by its effects, side effects, efficacy, everything. Revolade being a relatively novel, newer drug that's not as old as that, but still. So L-Thrombopag should be used in 150 milligrams per day. So that's the highest dose to be used in any of the indications for which L-Thrombopag is FDA approved. 150 milligrams for people more than 12 years old, 75 milligrams for 6 to 11 years old, and for younger children 2 to 5 years old, 2.5 milligrams per kg should be continued starting from day 1. That we'll be discussing subsequently. Next slide, please. So that's the typical algorithm. This study was very beautiful study that tried to compare 3 cohorts of patients in terms of outcomes. So first cohort had received ATG, cyclosporin, and L-Thrombopag. So at various time points. So the cohort 3, as we can see in this, L-Thrombopag was started from day 1 and cyclosporin was started from day 1. In the second cohort 2, the cyclosporin was started from day 14 till 3 months of the treatment, and Revolade was similarly started from day 14 till 3 months. In the cohort 1, the L-Thrombopag and cyclosporin was started from day 14 till 6 months. So that is a difference, and what the investigators found was cohort 3 was had the best outcomes that we shall see subsequently. Next slide. So as we can see here, in across all age groups, if you see the chances of response, the outcomes are favorable, comparable maybe in cohort 1 and 3, but the best outcomes overall are in cohort 3. So that means that probably justifies us. So why this study was developed, I'll just give a pretty second to this, was that there was a previous thought process that cyclosporin should never be started along with ATG. The reason being, ATG being a lympholytic agent and cyclosporin being lymphoid depleting agent. So these should not be given combination but in succession. So that was the thought process that was initially given, and that was the reason why initially it was said that it should be given started from day 14. But then this study came and that changed everything. So that taught us that cyclosporin should be started day 1, and the outcomes are favorable as compared to when it started day 14. So day 4 instead of day 14, day 1 of cyclosporin, ATG, and L-Thrombopag when started, it results in the best outcomes. Next slide, please. So this again recapitulates the same thing. Cohort 3, as we will see, 94% overall response rate as compared to 87 and 80% response rates with cohort 1 and cohort 2. Next slide, please. So overall survival, there have been some suggestion that L-Thrombopag improves overall survival, although this is not statistically significant. That has been shown in this study. But yes, it's important for us that the survival, more important than survival, what is important for us is the overall response rate, at least for patients with aplastic anemia who are dealing with such a bad disease. If we can increase the TLC and prevent the patient from catching life-threatening infection, that is what is more important to us. Next slide, please. So that's the study that I was mentioning about, the scientific data on that, that says that the use of this immunosuppressive therapy results in improvement of bone marrow celerity, as can be seen in the blue dots at 3 months, and at the last in the figure 1 at 6 months, the greener dots are becoming more and more into bluer dots, and they are rising. So bone marrow celerity, maybe that was around 25% to begin with, that has increased to almost 75-80% at 6 months. Similarly, the CD34 is basically the stem cell count. So the stem cell count that was around less than 1% at baseline increased to slightly more than 1% at 6 months. So that is what we have understood. With the use of this cocktail of these 3 drugs, the stem cell count celerity can be significantly improved in patients with aplastic anemia. Next slide, please. So this we have already discussed. Next slide. So what is the importance of maintenance cyclosporin? Next slide. So there was a time when we were discussing about this thing. So 3 months and cyclosporin stop. So then came the data, give for 6 months, then stop. But now we are realizing that cyclosporin should not be stopped at 6 months. It should be continued for at least 1 year and preferably for 2 years, depending on response. The patient responds to the treatment with this cocktail, continue the cyclosporin Revolade beyond 1 year and see the response rates. If the patient is maybe having complete response, then gradually try to taper and stop these medications beyond 1 year. So continuing cyclosporin and L-Trombopag beyond 1 year has been shown to improve outcomes in terms of response rates for patients with aplastic anemia. Next slide, please. So relapse-free survival definitely improves. The chances of being in sustained remission after stopping of cyclosporin and Revolade with this combination are higher as compared to when we stop this medications at 6 months. Next slide. This we have discussed. So this is the point actually. Clonal evolution was seen in 8%. So that is less than 10% of patients do have experienced clonal evolution, and that's one of the limitations that's being considered for ATG-based therapy. But nevertheless, the chances of progression to leukemias, the bigger blood cancers, has not been that high. It's around less than 1% for such patients, even who develop clonal evolution. Next slide. Safety data. Next slide. So these are the side effects when we used this combination of therapy: febrile neutropenia, serum sickness, and transaminisemia, and a maculopapular rash related to various drugs, be it be cyclosporin, be it be ATG, or be it be Revolade. Usually these are manageable. Next slide, please. Next slide, please. So the conclusion of this study was the L-Trombopag can induce a tri-lineage hematological response that can be sustained. The combination of these therapies represents first-line treatment option now, and the cyclosporin Revolade should be started at day 1 rather than waiting till day 14. The safety profile is good at a dose of 150 milligrams. Next slide. In the interest of time, I'll just wrap up here, and I'd like to conclude by saying that aplastic anemia has seen a sea change in the treatment paradigm. The shift has been huge. The availability of newer drugs, newer molecules, and the safety now with which we can do the stem cell transplant for such patients has improved humongously. The patients with aplastic anemia do need and do deserve a cure, and that's the motto in 2021, that patients with aplastic anemia should get a cure rather than just a symptomatic relief or a control or an improvement in their blood counts. So with this note, with this a positive note, I'll hand over the thing to Dr. Angela for any questions if there are any.
Right. Thank you so much, Dr. Meet. Really appreciate a wonderful talk. And there are a couple of questions in the Q&A box. If you can please answer them. There is one by Dr. M. Kulkarni.
What is that? Can you read out the questions?
Sure. Can human placenta extract be tried for SAA maintenance?
See, there is no clinical data, that much I'm very sure. As of now, there are a lot of things that are being tried on experimental basis, but as of today, in clinical practice, have not heard of this being used either across India or across the world, not for clinical purpose.
Right, thank you so much. There is another one question from Dr. Ganesh. Transfusion options, PRBC, PIT, and WBC.
So I didn't get it. The question is?
Transfusion options, PRBC, PIT, and WBC.
Okay, so the transfusion options for aplastic anemia, sir, it essentially means that when the hemoglobin is less than 8 grams per deciliter, the patients need a blood transfusion, or if the patient has a cardiac comorbidity, then we intentionally try to maintain the hemoglobin above 10. So that justifies that whatever transfusion requirement it may take us to maintain a hemoglobin of more than 8 and 10 in cardiac patients, we will do transfusion accordingly. For platelet transfusions, the target usually is to maintain more than 20,000 of platelet count. So if it requires once a week, once a month, twice a month, or once in 2 months, so whatever frequency it requires, the intent is to keep platelet counts more than 20,000 or keep the patient symptom free from bleeding perspective. As far as WBC transfusions are concerned, that we usually reserve for patients who are septic, infected, or who are having some serious infection inside them that is probably visible in terms of fever or symptomatic in terms of pneumonia, in terms of gastroenteritis, or other source of infection. If the patients have such presentations, in those cases only we restrict to use the WBC counts. Yes, as a desperate measure, sometimes we do resort to using growth factors like GCSF filgrastim when we are in desperate intent to start or like hasten the required recovery of the neutrophil counts. But as I said previously, the best hit or the best chance for us to recover the patient's neutrophil counts is to go for an emergency transplant rather than waiting for this type of treatments in such patients.
Right, Dr. Meet, thank you so much for answering both the questions. Another small question while you were talking about ATG, it can be derived from which animals? I think there was some network issue, probably I missed it. So can you quickly brief us on that, please?
So ATG is basically anti-thymocyte globulin. So it's a very interesting process how it is derived. So human have got a small organ called thymus behind the thyroid gland, and the lymphocytes inside our body usually get stored primitively at that organ when we are developing in our in the younger age groups. So the lymphocytes there that are stored there are called thymocytes. By do is just use these lymphocytes, prepare a suspension of that lymphocytes, and it is injected into the blood of various animals to provide the antibodies that will be subsequently developed by exposure to these lymphocytes. So the animals that have been used for such a use is the most preferred organ is horse, because its development capacity to antibodies is quite high. So the most common use is horse. The second one is rabbit. Sometimes in other countries, pigs have also been used to derive this antibody based from the blood of these animals. So it's a general contention. The efficacy of such a preparation is more if organism is smaller. So the rabbit ATG will have a more potency as compared to horse ATG. So that's a general contention. Smaller the organism or smaller the animal, the more efficacious it is in terms of treatment of immunosuppressive or autoimmune diseases.
Thank you so much, Dr. Meet. Really appreciate. Any questions? Any other question from the panelists, please? Any question for Dr. Meet? Okay, if not, then I would like to thank you once again for your valuable time. And
thank you so
have a great evening. Thank you. On special request, Dr. Vijay has actually accepted to stay for a few more minutes because there were some important questions which we wanted him to answer. So is Dr. Colonel Vijay still there? Dr. Langer, are you still there? Hi, sir. Thank you so much. Really appreciate that you have come back
Thanks.
because there were some important questions for you, and we'll appreciate if you can help us with the best solution.
Sure, ma'am.
So this is all regarding the pre-hospital care. In case of a large burn, say for example, a full body burn or relatively a large burn, do you advise that water should be poured on it or there is a risk of shock? And if we see the signs of shock, then how do we manage that pre-hospital setting?
Nice question again. All your questions have been fantastic from the floor. So yeah, this is tricky because we have to pour water. At the same time, the patient might go into hypothermia. But the bottom line is that the water has to be poured, because that will definitely reduce the impact, the damage, and the pain relief. So the patient in a large burn can die of hypovolemia, but usually in today's in current medical scenario, most people don't die of hypovolemia. It's the pain relief and so on, the problems. Usually people die of sepsis. So the answer to that is water will have to be poured. In children, however, with major burns, they can definitely go into hypothermia. So let's say if water should be poured for only 5 minutes instead of 10 minutes to 15 minutes in the adult, and then the child should be wrapped in a cotton dressing or cotton padding and so on, so that the baby does not go into hypothermia.
Right, sir. Really appreciate. So that was the burning question, why we requested you to appear again and help us with the solution. Really appreciate your time. Thank you.
Thank you very much. So kind of you. Thanks.
I would now like to invite Dr. A.P. Dubey, our next speaker, please. Dr. A.P. Dubey is consultant, Shanti Mukund Hospital, Delhi. He'll be talking about approaches to blood disorder. Dr. A.P. Dubey has been a dedicated medical oncologist and hematologist, treating solid malignancies like breast cancer, lung cancer, gastrointestinal cancer, including stomach and colorectal cancer, genitourinary such as kidney and prostate cancer, head and neck cancer, and earnest inclination in treating hematological disorders, malignancies like acute leukemia, multiple myeloma, anemia, including aplastic anemia. He has been a dedicated teacher in teaching clinical and bedside medicine to both postgraduates as well as undergraduates since 4 years. So I welcome Dr. A.P. Dubey, please.
So, hope I am audible to all.
Yes, sir, you are.
Yeah. Good evening, everyone. Thanks to Novartis and the organizing team who has given me this opportunity to speak on this particular topic, the disease awareness of about myelofibrosis and polycythemia vera. Can someone change slides for me? Next. So I'll start with a case. This is a case of a 62-year-old school teacher who has presented to her physician with the chief complaints of fatigue as well as night sweats, though she was correlating her complaints to the menopausal status that she has achieved around 7 to 8 years back. But further assiduous analysis of family history revealed that night sweats have become more intense and more frequent in the recent months. And also she had lost a significant loss of body weight was there. There was no history of any chronic illness in the past. And also she has not been dieting. However, she says that she cannot eat well. That means she was also complaining of early satiety. Next. So this was the complete blood examination which was been ordered for this patient. Generally, we cannot call this as a complete blood examination because there are many things which are not presently available in this, because a complete blood count is a Coulter report. Whatever Coulter numbers, numericals are there, and the histograms and the scatter plot, actually I consider that as a complete blood count, because each and every number is important, each and every graph and the scatter plot is important. So this was whatever limited information we have, and also the physical examination revealed the bruising on the extremities, and also there was palpable splenomegaly. As you can see, CBC report, you can find that there is increased WBC count, that 12,100 per cubic millimeter. There's a mild decrease in hemoglobin, as well as platelets are normal. Though peripheral blood smear, they have only given a limited information about blasts are 0%, but generally one should, there's any left shift or atypical cells or abnormal cells are present or not, it is not been given. So other biochemistry evaluation revealed that there was increased value of LDH. So physician decides to refer the patient for bone marrow biopsy and cytogenetics to predict the possibility of myeloproliferative neoplasm. Next. So before we go further into this particular case, why we are suspecting a myeloproliferative neoplasm in this, that I'll discuss. First, we'll be dealing that what are actually myeloproliferative neoplasm. Myeloproliferative neoplasms are chronic myeloid disorders, which are attributed due to the genetic abnormality which are being present in early myeloid precursors. So other chronic myeloid disorders are MDS. The difference between MDS and MPN is that in MDS there are early progenitor cells which are being proliferating, whereas in myeloproliferative neoplasm there are terminal myeloid precursors which are proliferating. So what happens, that genetically altered hematopoietic stem cell result in abnormal production of myeloid precursors, myeloproliferation, which includes hematopoiesis and thrombopoiesis. Next. Next. So what actually myeloproliferative neoplasms are characterized by? They are because of abnormal production of myeloid precursor. There is increase which include hematopoiesis and thrombopoiesis. So there will be increased production of one or more components of blood, and there will be constitutive activation of tyrosine kinase molecules. So what happens? Generally, the activity of tyrosine kinase is well balanced by the receptor mediated signaling as well as the negative feedback mechanism. But here what happens, that tyrosine kinase becomes constitutionally active, which result in abnormal and uncontrolled proliferation of these myeloid precursors. So generally there are many myeloproliferative neoplasm what we are aware of. So they are broadly they are being classified as BCR-ABL1 positive, that everyone knows that it is chronic myeloid leukemia, and BCR-ABL1 negative, that I'll be showing in the next slide. Next. So these all are the myeloid neoplasm. The chronic myeloid leukemia is one of the myeloid neoplasm which is very specifically defined genetically, associated with the reciprocal translocation between the chromosome 9 and 22, resulting in a fusion protein BCR-ABL1, which has got a constitutive tyrosine kinase activity, which results in abnormal proliferation of these myeloid precursors. Other myeloid proliferative neoplasms are essential thrombocythemia and polycythemia vera, and so on. So all these myeloproliferative neoplasms are also having tendency to transform into MDS or acute myeloid leukemia, though there is variation in the magnitude of these tendency of transformation. For example, this is highest in chronic myeloid leukemia. If untreated, around 95 to 100% cases will transform into acute myeloid leukemia, where it is least in the case of essential thrombocythemia. Next. Next. So these are the different common myeloproliferative neoplasm which we know, and the incidence, as we can very well see that the incidence of chronic myeloid leukemia is almost highest along with the polycythemia vera, which is around to the tune of 2 to 3 per lakh of population, and there are other, whereas other myeloproliferative neoplasms are actually infrequent. Next. So we'll continue with the case report because of there was clinically patient was complaining of constitutional symptoms, which constitutional symptoms were because of the could be in the setting of myeloproliferative neoplasm because of the constitutive activation of tyrosine kinase, which result in increased production of inflammatory cytokines. And secondly, early satiety, which was due to the splenomegaly, because splenomegaly was present. And thirdly, there was also increased production of WBCs. So all these, if put together, they give a suspicion of myeloproliferative neoplasm. Though a PBS picture was not present, if PBS picture is present, that can very easily help us to diagnose. And my friends, whenever we see any abnormality in complete blood count, the first and foremost test to be ordered is peripheral blood smear, because it gives us immense information and also help us to taper the differential diagnosis. So result from the bone marrow biopsy showed megakaryocyte proliferation and atypia with the evidence of reticulin fibrosis. So here there was evidence of fibrosis, and also there was megakaryocyte proliferation, because there is tendency for myeloproliferation in these disorders because of constitutive activation of tyrosine kinase. So that all was present in bone marrow. And the blood smear shows leukoerythroblastosis. So what is this leukoerythroblastosis? This is actually typical in myelofibrosis, because what happens that because of myelofibrosis, the bone marrow is not able to produce adequate hematopoiesis, and that results in pushing of immature precursors into the peripheral blood, and also shifting of hematopoiesis to the extramedullary organs like liver and spleen, resulting in hepatosplenomegaly. So the abnormal and immature cells, and sometimes blast too, in the peripheral blood picture, along with extramedullary hematopoiesis resulting in hepatosplenomegaly, gives us the complete picture of leukoerythroblastosis. This patient was BCR-ABL1 negative and JAK2 positive. I must tell you here that JAK2 positivity is seen mostly in polycythemia vera, where almost more than 95% of the patient will have JAK2 positivity, whereas in other myeloproliferative neoplasm like essential thrombocythemia and myelofibrosis, JAK2 positivity is to the tune of 50 to 65%. Next. So this is the diagnostic criteria of primary myelofibrosis, which is megakaryocyte proliferation and atypia, means atypical cells, means abnormal cells, accompanied by reticulin fibrosis, which was also there in our patient, and that could not be attributed to some other cause. And the patient should not be meeting a criteria of CML, PV, ET, or MDS, because if the patient is meeting the criteria of these primary disorder, then the fibrosis, whatever it is related, it will be called as secondary myelofibrosis, not primary myelofibrosis. And there should be some presence of genetic abnormality, though it is present at the diagnosis in myelofibrosis, it is present around 30 to 40% at upfront, but during evolution could be present in more than 50 to 65% of the patient. So then the minor criteria is anemia, leukoerythroblastosis, which was present, palpable splenomegaly, and increased serum LDH, which was also present in the patient. So in the patient must meet 3 on 3 major criteria and at least 1 of 5 minor criteria to be called as, or to be labeled as, primary myelofibrosis. Next. Next. So myelofibrosis is a condition where the bone marrow, which is a source of hematopoiesis in our body, is actually replaced by the fibrous scar-like tissue. So there, what happens? See, you can see that the hypercellular marrow is converted, or you can see the reticulin fibrosis in the, and the marrow is not so much hypocellular. So this can happen in all the myeloproliferative neoplasm, but when if it is happening upfront without any history of other myeloproliferative neoplasm, it is primary myelofibrosis. But if it is happening in the setting of prior diagnosed myeloproliferative neoplasm, it is known as fibrosis. Next. And as I've told that all these myeloproliferative neoplasm have tendency to transform either into MDS and or AML. The incidence of transformation into AML is higher in CML, but with the evolution of first, second, and third generation TKIs, now the overall survival of the patients of chronic myeloid leukemia chronic phase has been nearing to the general population. Only the patients of chronic myeloid leukemia who are not treated, there more than 95% of the patients will get transformed to acute myeloid leukemia. And whereas in other myeloproliferative neoplasm, the tendency to get transformed is low, and in essential thrombocythemia, it is the least. Next. So this is what I was saying about the bone marrow fibrosis. There are two phases. Initially, the bone marrow is hypercellular, so there will be increased production of one or more other type of cells. With it, there will be megakaryocyte hyperplasia, as well as there will be ATPR. Whereas when the disease progresses and it transforms into fibrotic phase, there is continuous formation of abnormal megakaryocyte clusters that remains, whereas there will be decreased marrow cellularity. The marrow which was hypercellular initially becomes hypocellular, and there will be gradual replacement of bone marrow with that of fibrosis, reticular fibrosis, and there will be thickening of bone and increased vascularity of the marrow tissue, that is known as osteosclerosis. Next. So once the primary source of hematopoiesis is been gone or is being compromised, so what happens? Body has to get the hematopoiesis from somewhere else. So it happens in extramedullary tissues, the extramedullary organs, that liver and spleen, that result in their enlargement, and that enlargement will result in the symptoms of that patient, because splenomegaly will result in abnormal left discomfort and also early satiety. Next. So this is the phases of the myelofibrosis, from the hypercellular marrow to hypocellular marrow to the addition or the presence of the reticular fibrosis. Next. So as I've told that if myelofibrosis occurs without prior diagnosis of any myeloproliferative neoplasm or other disorder, it is known as primary myelofibrosis. But when it happens in the setting of prior diagnosis of polycythemia vera or essential thrombocytopenia, it is known as secondary myelofibrosis. For that, these are the criteria where what has to be met for secondary myelofibrosis in the setting of polycythemia vera or essential thrombocythemia. As we all know that in polycythemia vera, the patient require phlebotomy. Whenever there is a decreased requirement of phlebotomy in the patient and there is decrease in hemoglobin concentration by at least 2, and the presence of leukoerythroblastic picture, we should have a suspicion, very high suspicion, that these patients are transforming into myelofibrotic. Next. A prognostic scoring system, so as because whenever a patient is diagnosed with any of the disease, the attendants or the patient himself or herself asks the doctor that what will happen to me, what is my overall survival, what is my overall outcome. So for that, there are prognostic scoring symptom, that is IPSS, DIPSS, and DIPSS plus, depending upon the number of factors or the characters they are taking. The IPSS is the most commonly used scoring system, which consists of age, constitutional symptom, anemia, WBC count, and circulating blast cell, whereas other scoring systems are using platelet counts and the need for transfusion as well as cytogenetics. IPSS is the most common, but it is not using cytogenetics. So this, depending upon the IPSS risk, the survival is being predicted. If the number of factors, risk factors, are more than 3, it is high. The median survival is around 2.3 years. If none of these factors are positive or the characters are positive, then it becomes IPSS category low, and the overall survival, median overall survival is 11.3 years. Next. So this is the case report for what the patient. This patient had 2 risk factors, so that patient becomes that of intermediate risk. So the median survival becomes 4 years. Now we are able to tell to the patient what actually is going to, or we can tell to the attendants, we can explain the prognosis. So what is actually prognosis is the overall outcome of the patient irrespective of the treatment. And certain treatment strategies can change this prognostication with the evolution of the molecular therapies and the targeted therapy which are coming in in the field of the diseases. Next. These are the three interrelated concerns comprise the disease burden of myelofibrosis. First, in myelofibrosis, because of the ineffective hematopoiesis, there will be cytopenia. Cytopenias will surely next will result in the symptoms of cytopenias like anemia, that will result in fatigue, loss of concentration. Platelet abnormalities will result in bruising or bleeding. And because extramedullary hematopoiesis will, then the patient will have hepatosplenomegaly, which will result in abdominal discomfort and early satiety. Next. This I guess I have explained. Next. The constitutional symptoms actually occur in the patient of myelofibrosis because it is a chronic inflammatory process. Why the chronic inflammatory process? Because of the constitutive activation of tyrosine kinase pathways, that is JAK-STAT pathways, which result in increased production of cytokines. Next. So splenomegaly because of the extramedullary hematopoiesis, which may result in abdominal discomfort, which may result in early satiety and other symptomatology of myelofibrosis. Next. So why there's cytopenia? Cytopenia because there's ineffective hematopoiesis. The main organ of hematopoiesis is compromised. So when it is compromised, so there will be decreased production of hematopoietic cells. So there results in anemia, which may result in fatigue, loss of concentration, tiredness. Next. And also splenomegaly, when it is a massive spleen, because myeloproliferative neoplasm are associated with massive splenomegaly. So that will result in sequestration of hematopoietic cell. That will further aggravate the cytopenia and thus the symptomatology of myeloproliferative neoplasm. Next. This, I guess, these are the broad range of symptomatology in the patient of myelofibrosis, which can range from fatigue to fever. And in between, you'll have the symptomatology because of cytopenia. You have the symptomatology because of massive splenomegaly. You have the symptomatology because of this cytokine, one way of mild cytokine storm because of increased production of cytokine due to increased activation of JAK-STAT pathway. Next. And all these symptoms will negatively impact the quality of life, as has been seen in the AML. Though AML is an acute myeloid disorder and myelofibrosis is a chronic myeloid disorder. Next. These are the several cellular and molecular changes that contribute to development of molecular myelofibrosis. We should know that generally there is increased activation or constitutive activation of tyrosine kinase. That's why there will be dysregulated JAK signaling, and which will produce increased number of inflammatory cytokines, resulting in all abnormal production of hematopoietic cells and also abnormal proliferation of the myeloid progenitors, ineffective hematopoiesis, and then progressing to reticular fibrosis, and then extramedullary hematopoiesis, splenomegaly, and other symptomatologies. Next. This is dysregulated JAK signaling, as I have told, because of the constitutive activation of tyrosine kinases. Next. This is whenever there is constitutive activation of tyrosine kinases, it will result in several cytokines in abundance. That will include tumor necrosis factor, interleukin-6, and that will cause all the constitutional symptoms like fever, loss of appetite, weight loss, and so on. Next. So this is what about the same thing. Bone marrow, initially it is hypercellular, then later it is replaced by reticular fibrosis, become hypocellular. Next. So our aim in this particular disease remains, first of all, to we all should have increased awareness, because this disease is seldom diagnosed at an early stage, or you can say at a right time when the patient actually present to the physician. So a disease awareness about this particular disease should be very much important, that what is symptomatology, what are the CBC picture, what are the PBS picture. I would request each of my friends that whenever they find such symptomatology of the patient, when they should first, history and physical examination remain the gold standard in medicine, and that cannot be replaced by any expensive investigation. So whenever such history comes out, you should get a complete blood count, and any abnormality in complete blood count, the first test to be ordered will be always peripheral blood smear, because that gives us immense information and that will help us to guiding our further information. Next. So this is the summary that Philadelphia negative myeloproliferative neoplasms, because Philadelphia positive myeloproliferative neoplasm is chronic myeloid leukemia. In that field, we have already done a lot, because first of all, the diagnosis of that now is quite easy, and we are able to diagnose. Every one of us are very much able to diagnose any patient who is coming with increased WBC count, with the preservation of all other lineages, like HB is relatively preserved, platelet is relatively preserved, and there is significantly increased WBC count with PBS showing left shift and the myelocyte bulge. You can easily diagnose, only clinically you can easily diagnose that it is chronic myeloid leukemia. But the problem is that the other Philadelphia negative myeloproliferative neoplasms are actually, you can say, the ignored at an initial presentation, because we have less of certain awareness that may improve with more and more disease understanding, more and more understanding of the symptoms, its presentations at complete blood counts, and how it can be evaluated easily, so as an diagnosis should be made at an earliest. So the disease burden of myelofibrosis comprises of 3 hallmark categories, that is splenomegaly. First, there will be splenomegaly, and because of the extramedullary hematopoiesis, and then ineffective hematopoiesis, because extramedullary hematopoiesis is not able to convey whatever adequate bone marrow was able to do. So they will be resulting in cytopenias, and also there will be constitutional symptoms because of the increased production of cytokines. Next. So this is a second case report where this patient comes with to the emergency department with certain history of claudication of right upper limb and the clumsiness. So, but he was denying any other history. Though he was having the history of frequent headaches in the past, but he was not a smoker. There was no history of any addiction, no history of any neurological or hematological disease, and even complete neurological examination does not show any focal neurological deficit. Next. So we could find that all the physical examination and the neurological examination were almost normal in this patient. What abnormality was seen, that hemoglobin was 19.3 gram per deciliter. That should, in a patient who is a non-smoker, staying in a plain areas, HB of 19.3 gram per deciliter should raise a high suspicion of myeloproliferative neoplasm, that is polycythemia vera, with a hematocrit of 61.6%. That gives a very high, very strong suspicion, and platelet 4,45,000 per cubic meter. Next. Next. So this is now whenever we get such thing, then we should get EPO levels, because for erythropoiesis, erythropoietin is responsible. In this patient, we found that there was subnormal erythropoietin levels. So, and then bone marrow is to be done so as to show the trilineage hematopoiesis. And you can see that this is the criteria of polycythemia vera. There should be evidence of erythrocytosis, means there should be elevated hemoglobin, which is more than 16.5 gram per deciliter for men and more than 16 in women. And there should be elevated, hematocrit, and bone marrow should show trilineage myeloproliferation and presence of JAK2. JAK2 mutation is present in around 95% of these patients. Either JAK2 C617F or exon 12. And to give the diagnosis or to label the diagnosis, patient should have either all the 3 major criteria, or first two major criteria plus one minor. Next. These are the characteristics of polycythemia vera, which we have already explained. Next. So what happens is, again here also, that constitutive activation of tyrosine kinase has resulted in abnormal proliferation of these cells, resulting in increased hemoglobin level as well as hematocrit value. Next. So this is how we have to see, or how we have to follow that, what should be the values, cutoff values for the patient whom we should suspect the polycythemia vera. Next. Next. Then we have to, when we suspect, we have to do bone marrow. For bone marrow, why? Because to show the tri-lineage hematopoiesis, because it is one of the major criteria. And then the genetic studies, because JAK2 mutation is present in 95%, and if we include the exon 12, it is present in 99% of the patient. Next. So this is the condition which are because of the overproduction of RBCs, platelets, and WBCs, because it is associated with tri-lineage hematopoiesis. Next. Patients with polycythemia vera has both the increased risk of thrombosis. In the thrombosis could be present in around 1/3 of the patient, and that is associated with both arterial and venous thrombosis. And also, patients are also present with the bleeding, and because of the abnormal platelets, and that bleeding can be present in up to 10% of the patient. Next. 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 So these are the constitutional symptoms and general polycythemia vera symptoms. What the patient comes, and one, we should fatigue. Though patient HB will be high because of the increased viscosity, increased hematocrit, patient will have fatigue, patient will have pruritus, and with the warm water bathing, patient will have aggravation of pruritus. There will be constitutional symptoms, bony pain, fever, and there will, because of splenomegaly, patient will have abnormal discomfort and early satiety. Next. These are the most common symptomatology, though fatigue and pruritus are the most common. And when we do the CBC, we find increased HB and hematocrit. Next. So pruritus is the common and severe symptoms of polycythemia vera, which is debilitating in 15% of the patient. Next. So again, all these myeloproliferative neoplasm are known to negatively impact the quality of life because of their disease burden. Next. So as I was telling, that these all patient can have, because of the increased production of these cells, that also abnormality that may result in microvascular and macrovascular complication, thrombosis, and the bleeding tendencies. Next. These are the microvascular hematological complications of PV. Patient can have transient ischemic attack. Patient can have neurological like headache, dizziness, blurring of vision, and redness, burning, pricking. Next. These are the macrovascular, which involves CVAs or cardiovascular disorder like myocardial infarction, pulmonary embolism, or thrombosis, which can be seen in around 1/3 of the patient. Next. Splenomegaly is more common in the later stages of polycythemia vera, and that is one of the early signs, so that one must suspect a myeloproliferative neoplasm, because massive splenomegaly is seen in the patients of myeloproliferative neoplasm. Next. This is what we have told, that patient will have all these symptomatologies. Next. Next. Thrombotic and bleeding both are common. Thrombosis, both arterial and venous thrombosis. And then there is risk stratification, low risk, a patient less than 60 years with no history of thrombosis, and high risk with age less than 3 years. Generally, I would like to limit the talk with the characteristics to identify these disorders rather than treatment of these disorders. Next. And all these can progress to myelofibrosis, that is known as secondary myelofibrosis, and MDS and AML. The tendency to transformation of AML in polycythemia vera is less than CML, but higher than essential thrombocythemia. Next. Next. Here also our main aim is to comprehensive disease control, which can be done by managing the debilitating symptoms, reducing the risk of thrombotic and hemorrhagic events, and minimizing the risk of progression. Next. This is a summary. So to summarize both the things that Philadelphia negative myeloproliferative neoplasm, they are seldom diagnosed at right time. So one must have a disease awareness that because these patients will generally present with the constitutional symptoms. And if in case of polycythemia vera, patient will present fatigue and pruritus. In case of myelofibrosis, patient will present with fatigue as well as abdominal discomfort. Abdominal discomfort can be common in both polycythemia vera as well as myelofibrosis because of the splenomegaly and also that early satiety. Thrombotic and thrombotic symptoms or thrombotic complications are more common in patients of polycythemia vera. And about the genetic abnormalities, JAK2 mutations are seen in around more than 95% of the polycythemia vera, whereas in if you take a case of primary myelofibrosis, they are present in about 60 to 65% of the patient. Splenomegaly is more extensive, and if these diseases are not treated, they tend to progress into the fibrosic phase because initially there is a hypercellular phase. PV also can transform into secondary myelofibrosis and AML, whereas primary myelofibrosis from hypercellular transform to fibrotic stage and also can transform to MDS or AML. So comprehensive knowledge about these diseases, symptomatology, their presentation, and their evolution should be important so as an early diagnosis to these, both the disorders or the Ph negative myeloproliferative neoplasm should be done at right time. Thank you.
Dr. Dubey, thank you so much for your time and the wonderful presentation there. We have a question for you we have a couple of questions for you in the Q&A box. If you could please answer them. One is from Dr. Satya Devi. The last two questions, if you scroll all the way down in the Q&A section, the last two questions are for you.
Sir, in the absence of thrombocytosis and malignancy, can only erythrocytosis cause the complication secondary to thrombosis? If, madam, if you want to ask that, can erythrocytosis can lead to thrombosis? Yes, they can. And if, like if you are asking that in the absence of malignancy or thrombocytosis, so malignancy itself is a hypercoagulable disorder. Thrombocytosis also can result in thrombosis as well as bleeding disorders because of the increased viscosity, and similar thing goes for erythrocytosis because of increased viscosity. The microcirculation and the macrocirculation are compromised, that may result in thrombotic disorders.
Right, and from Dr. Ganesh, there is one question. If you
the anticoagulants in polycythemia vera, yes, they are must, and ecosprin should be given initially, starting with the dose of, depends that what patient is able to tolerate, but initially I start with a dose of 150 milligram.
Right, Dr. Dubey, thank you so much for your time. Really appreciate.
Thank you.
And have a wonderful day ahead. Thank you. I now welcome Professor G.C. Khilani, Chairman, Pulmonary Critical Care and Sleep Medicine, PSRI Hospital, New Delhi. Dr. Khilani would be talking about Understand IPF and SSC-ILD and Care in COVID-19. Dr. Khilani is the Chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine having 41 plus years of experience in this field. He was also head and professor of Department of Pulmonary Medicine and Sleep Disorders in AIIMS, New Delhi. He is having expertise in pulmonary and critical care medicine and sleep medicine. He did fellowship in critical care from Mount Sinai Medical School, New York, US. He's chairman of Credential Committee of Indian Society of Critical Care and Medicine and member governing body of Indian Chest Society. And he was vice president of National College of Chest Physician. Also president for 2 terms for National College of Chest Physician, chairman Credential Committee of Indian Society of Critical Care. He's also senior editor of Critical Care. I welcome Dr. Khilani. The floor is all yours now.
You have to unmute me, allow me to unmute so that I can talk.
We can hear you well, sir.
All right. Okay. All right. So, good evening, ladies and gentlemen. Am I audible?
Yes, sir, you're audible.
Okay, all right. All right. So, thanks, Dr. Angela Sharma, and thanks to Dr. Sandeep Sharma from ONGC and the Boringer for bringing me in front of you and talking about understanding IPF, SSC, ILD, and care in COVID-19. 3 topics, 40 minutes. Rarely I get a chance to talk for that length of time. But actually there are 3 subjects. And my job is to relate these 3 because I'm sure everybody is interested in pulmonary fibrosis related to COVID, and you may not be that keen to know about intricacies of idiopathic pulmonary fibrosis because it's a domain of pulmonologists and of course scleroderma with lung fibrosis or lung involvement is a domain of hematologists and pulmonologists. But nevertheless, there has been 3 diseases and 1 solution. And that's what the theme of today is. One is interstitial lung disease, idiopathic pulmonary fibrosis. Another is, of course, scleroderma with ILD. And what is everybody is interested today is post-COVID pulmonary fibrosis. And these are 3 CTs are exemplifying these 3 diseases, which actually are, all 3 are dreadful diseases. And there is nobody in the world, what to talk of India, either they have known somebody in the family who has got a crippling disease or have lost their lives, or in the office or in the vicinity. So COVID has actually caused mortalities. I need not recite the numbers, but it has also caused crippling disability in the terms of pulmonary fibrosis, which leads to a person to be disabled. Some people are on oxygen, some people continue to be in ICU for months together, some are on ECMO, some are struggling for lung transplantation. So the common features of all 3 diseases are that the person is breathless. As I said, it is a crippling for patients. There is a lung fibrosis. There is a reduction in lung function and reduction in 6-minute walk test. And therapy is aimed at improving the lung functions, but quite often we look at reducing the decline in lung function rather than, because those kind of remedies may not be available. The interest comes in the fibrosing interstitial lung diseases, and there are several types of them. Today's focus is idiopathic pulmonary fibrosis and ILD is associated with connective tissue diseases. And if we talk about epidemiology, the idiopathic pulmonary fibrosis forms something like 8.5% of all interstitial lung diseases, commonest in India being hypersensitivity pneumonitis. So I start with the case. This is a about 60 years old male who presented with cough, shortness of breath. He said that while walking, climbing stairs, he become short of breath. So physician or pulmonologist would think about COPD, emphysema, congestive cardiac failure, and how to proceed with initial evaluation. You do an X-ray chest. You have already seen the X-ray. You do a PFT. You do a 6-minute walk test, and do an HRCT. So diagnosis of interstitial lung disease starts with the history and physical examination, pulmonary function test, HRCT, and finally, before the advent of HRCT chest, the histopathology was considered very important, and I'll come to it later. So this particular patient, you could see reticular shadows in the X-ray. There's hyperinflation also. He was a smoker. But when the CT was done, we saw there is what you call classically called as honeycombing. So the diagnosis of interstitial lung disease was established, but there were no comorbidities like no connective tissue disease. There was no history of occupational or environmental exposure, no history of drugs associated with ILD, and connective tissue markers were negative. The histological diagnosis of interstitial lung disease is obtained by bronchoscopy, that is, you do a bronchial biopsy. You can do a video assisted thoracoscopic biopsy, which would be a gold standard, or open lung biopsy. And nowadays, we don't do biopsies very often. And we depend upon the HRCT chest based on which we treat them. And radiology is actually very important. And as you see, if you see at the periphery, what you see is interstitial thickening, and this is exemplified by this this cartoon made. There is a honeycombing, as you see in the cystic lucencies, and these are the two hallmarks of idiopathic pulmonary fibrosis that you see. And there are various types of ILDs I already described. And in India, 47% of the ILDs were actually hypersensitivity pneumonitis, especially to the pigeons. And you must have read in the newspapers also. People have written that, you should not feed pigeons and don't let the pigeons come near. Although it's a little religious thing to, unko dana chogana, acha mana jata hai. But it is most important cause of hypersensitivity pneumonitis. So what is idiopathic pulmonary fibrosis? It's a chronic progressive disease characterized by accumulation of fibrotic tissue in the lung parenchyma associated with significant morbidity and poor prognosis. And there's a complex interaction between genetics and serious injuries which triggers a fibrotic process. It occurs worldwide, but it is still idiopathic. We really don't know the cause for this. And there are certain risk factors which are recognized, along with family history, old age, smoking, environmental exposure, male gender, and occupational exposure. And some people think that viral infections are also important. So this is a normal lung, normal alveoli, as you see. And if you see idiopathic pulmonary fibrosis, the alveoli are destroyed. There is areas of fibrosis exemplified by honeycombing, and it is more in the lower lobes. This is the healthy part of the lung, and this is the diseased part of the lung. What happens that because of the fibrosis, this is the normal flow volume curve. All the volumes in the lung goes down. So the lung capacity is reduced. And this is the natural history. This is the survival percentage and the time in the years. For several years, the symptoms are mild and it is not recognized. Here, the onset of symptoms is there, and there is repeated exacerbation which further leads to decline in the lung, and this is lead to death. The average survival before the treatment which I'll be describing, was 3 to 5 years. And people who come to us with diagnosis of ILD, they go on the Google and read this, that their survival is only 3 years. They really get horrified. These patients have shortness of breath as the main symptom, a dry, hacking cough. They get fatigue. There is a weight loss which is relentless. There's muscle and joint pains, and there's the clubbing of the fingers. So these are the main clinical features of. Usually the onset is gradual, and quite often it is mistaken for cardiac disease, aging, emphysema, bronchitis. When I started my career almost 30 years back at the All India Institute of Medical Sciences, majority of patients with ILD had received antitubercular treatment because that is considered the most common cause. And as I said, survival, if you compare to the malignancies, so many of cancers, the IPF survival is much less. So the clinical approach, as I have already described, history, physical examination, and pathology, nowadays we are less dependent on that. So what about the treatment? And as I have grown up with pulmonology, as in my introduction said, 41 years of experience, that's not important. But actually, I have seen treatment of IPF evolve when we were giving only steroids and then azathioprine and then other cytotoxic drugs. Everything was dumped from 1970s to 2014 when the pirfenidone and nintedanib were approved by US FDA. That actually changed the practice. So quickly coming to the treatment, management of idiopathic pulmonary fibrosis, the non-pharmacological management, pharmacological management, and surgical management. I'll not be talking about it. That is the smoking cessation, pulmonary rehabilitation, vaccination with flu and for influenza and pneumonia, oxygen therapy, managing the gastroesophageal reflux, and sleep disorders. Lung transplantation is an answer, but it's very sparingly available, especially in northern India. And pharmacotherapy remains the main treatment. And out of which the pirfenidone and nintedanib are two anti-fibrotic drugs which have proven with randomized controlled trial. So as I was telling you the history, in the year 2000, we were giving steroids with cytotoxic drugs, cyclophosphamide. This was mentioned in our textbook of Murray and Nadel, that is, I consider as the Bible of pulmonary medicine. And then came steroids and cytotoxics with N-acetylcysteine, that is Infigenia trial. And then came 2011 when other drugs were used like bosentan, interferon, sildenafil, and everything was given up. Finally came pirfenidone and nintedanib with capacity 1 and 2 and ascent trial and impulses 1 trial. So all were against. Only pirfenidone and nintedanib, as far as the American Thoracic Society guidelines, there was a conditional recommendation for that. So coming to the drugs like pirfenidone, that's called nuts and bolts of interstitial lung disease or interstitial fibrosis. The pirfenidone inhibits TGF-beta collagen synthesis, stimulated collagen synthesis, and the dose is 40 milligram per kilogram per day and maximum up to 2,400 milligram. It's not easy to tolerate pirfenidone. Those of you who have had the experience of giving it to your patients or having seen being given, it causes photosensitivity, causes nausea, dyspepsia, LFT gets deranged, and GI adverse effects occur in as many as 18% of cases. But what it does in idiopathic pulmonary fibrosis is it reduces the decline in lung function, and this is the study which is showing, and it also improves the survival. That means it reduces the mortality. And this is placebo as compared to the pirfenidone. And same thing, as I said, when you are treating idiopathic pulmonary fibrosis, you don't look at the improvement in the vital capacity. What you look at, if you don't give pirfenidone, the vital capacity goes down like this. If you give pirfenidone, vital capacity still goes down, but the rate of decline is slowed down, and that is significantly. And that has been proved by several trials. Now, another drug that I'll be talking about is nintedanib. It's a tyrosine kinase receptor blocker. This is both the drugs, incidentally, were approved in 2014, one day before the American Thoracic Society meeting, and I was incidentally present in that meeting in US. And there was such an enthusiasm about, as if a new treatment for idiopathic pulmonary fibrosis has come. The dose is 150 milligram twice a day. And this also leads to diminished decline of pulmonary function, leading to improved survival. What nintedanib has advantage over pirfenidone is the dosages are little simpler, but also there is a scientific evidence that reduces the exacerbation, and each exacerbation leads to decrease in lung function and increase in the mortality. So the median difference in vital capacity is 125 ml, which was statistically significant. So important landmark in antifibrotic therapy is 2010 DCGI approved pirfenidone. Pirfenidone was approved in India much before it was approved in US. And 2014 nintedanib was approved because of the ASCENT trial. In 2014, as I said, US FDA approved both the drugs for pirfenidone as well as nintedanib. 2016, DCGI approved nintedanib for IPF, and 2018, the DCGI approved nintedanib for scleroderma, which I will be describing. So this is the timeline for, and then subsequently nintedanib was found to be useful for fibrotic diseases other than idiopathic pulmonary fibrosis. So nintedanib is a small molecule, as I said, tyrosine kinase inhibitor. It binds intracellularly to the ATP binding sites of FGF, PTGF, and VEGF receptors. And I probably should not go into the intricacies of the mechanism, which may bore you. So it causes anti-fibrotic action, it has anti-inflammatory action, it also has antioxidant action. And this is the trial that I was talking about, that impulses trial for fibrotic diseases. So I think I'll have to be quick in going to the next subject and probably spend a little more time on COVID, which would be of interest to you. And nintedanib versus pirfenidone has been compared in a review and meta-analysis, and it has been seen that nintedanib is more potent in reducing the exacerbations of IPF as compared to pirfenidone, although both you can see are on the left of this forest plot. So therefore, both the drugs are good. Both the drugs have shown benefit in survival. Nintedanib has easy dosages, lesser side effects, and reduces the exacerbations. So, management of IPF, the summary is the pirfenidone and nintedanib are currently approved. Both these drugs have shown a favorable effect. Nintedanib also showed consistent efficacy with concomitant use, which represent 30 to 50% of IPF population. Nintedanib has shown to reduce risk of acute exacerbation and lower pill burden as compared to the 12 tablets of pirfenidone. You have to take only 2 tablets of nintedanib. Coming to the next part, excuse me, that is scleroderma. And I'm sure all of you have seen this faces of fish mouth of scleroderma with sclerodactyly and other tip ulcers. And all all the young ladies and middle-aged ladies who present with interstitial lung disease, we test them for variety of antibodies to rule out or rule in connective tissue disease. And for scleroderma, SCL70 antibody is the main diagnostic. So this is a 34 years old lady presented with skin tightening over the face, Raynaud's phenomenon. She had GARD, as she had dyspnea for last 4 months. Saturation was 95%, vital capacity of 56%, DLCO of 50%, loud P2 on auscultation. And this was the picture I have already shown you, diagnosis written on her face, and this was the CT. You can see there is the interstitial thickening, there is a traction bronchiectasis and fibrotic disease. This is classical, what we call as NSIP pattern, non-specific interstitial pneumonia. So there are criteria for scleroderma diagnosis which I need not recite. The standard treatment for scleroderma and ILD is cyclophosphamide, and there is a scientific proof that cyclophosphamide leads to improved outcome. Another drug which have been used is mycophenolate mofetil, that is MFF, popularly the trade name is Cellcept. Both the drugs are equally effective, and there is a head-to-head comparison of called a scleroderma trial. It's shown that both are equally effective, but there was lesser side effects with mycophenolate mofetil. So this is, some people prefer this. So treatment of scleroderma will be cyclophosphamide, MMF. Another drug which was added to is rituximab. Rituximab has, and we also use methotrexate. These are all intricate pulmonary medicine. But now came the census trial, which came in 2019. It was a randomized trial for fibrotic lung disease, where nintedanib was compared with the placebo, and the primary endpoint was after 52 weeks. It was seen that nintedanib reduced the decline in lung function, proving that nintedanib is not only useful for idiopathic pulmonary fibrosis, but it is also useful for other fibrotic diseases. So, summarizing it, that standard of care for scleroderma remains cyclophosphamide with steroids. Other drug which can be used is mycophenolate mofetil. Methotrexate can also be used. Rituximab can also be used. But as far as the lung fibrosis is concerned, that nintedanib reduced ILD progression in patients with scleroderma ALD, as demonstrated in the census trial, and it lowers the rate of decline in vital capacity over a period of 52 weeks. The annual rate of decline was minus 52.4 ml as compared to 93 ml in the placebo group, and relative effect of nintedanib versus placebo on reducing the rate of FVC was similar in the census trial as in impulses trial. Now, these are now intricate things which may not interest you, but it's a game changer for fibrosis related to scleroderma. So, nintedanib is approved by US FDA for ILD and scleroderma, also by European and also by DCGI. Now, coming to the COVID, I'm sure it will bring you out of your slumber of idiopathic pulmonary fibrosis, and so I purposely went a little faster to describe IPF and scleroderma, so that I'll have more time to talk about. So this is a 47-year-old male, a known diabetic and asthmatic, presented with high-grade fever for 10 days, breathless for 10 days. On examination, he was febrile with tachypnea. He had tachycardia with the SpO2 of 78% on room air, which increased with high flow support. Chest had bilateral clefts. ABG was showed PaO2 of 62 with high flow oxygen of FiO2 of 0.8. The the diagnosis was provisional diagnosis was COVID-19 or severe acute respiratory syndrome. Ultimately, it came out to be COVID positive. He was started on antibiotics, steroids, anticoagulants. Also received remdesivir. He had relative lymphopenia of 7%, as we have seen in these cases. CRP was high, D-dimer was normal, LDH was marginally high, ferritin was also high. So when the CT was done, and you can see the various cuts of the CT scan, peripheral ground glass opacities which are more in the lower lobes as classically. I'm sure all of you has seen the CT scan. So oxygen support and was continued. Remdesivir and tocilizumab was given. Convalescent plasma therapy was given, and patient was gradually improved and shifted to ward on oxygen support. Repeat COVID-19 PCR was sent, which came out to be negative, and patient was discharged. However, 7 days post-discharge, patient came to emergency department with complaints of severe breathlessness and ghabrat. Physical examination showed that he was afebrile with the pulse rate of 160, normal blood pressure. He had tachypnea of 30 per minute. SpO2 was 85% in room air, and PaO2 was 50 millimeter on ABG. And you see this kind of CT. Now he has gone into the pulmonary fibrosis, and you can see there is a traction bronchiectasis. You can see the dilated bronchi, intermingling fibrosis, and there are empty areas where there is no lung tissue. So there is a traction bronchiectasis, there is fibrosis. This is classical post-COVID fibrosis. And on day 3, now the PCR became positive after becoming, and this is what we have seen, and this is called dysregulated hyperimmune response syndrome. On day 3 of admission, that is second admission, he had sudden increase in breathlessness and tachycardia. X-ray showed right-sided pneumothorax, so ICT tube was put in. Immediate pigtail insertion was done, patient improved and pneumothorax got resolved, and pigtail was removed after 5 days. And I'll show you radiology of some more cases. This is the classical X-ray of a severe COVID infection with peripheral whitening, relative sparing of the upper zone. This is a CT of a person who has got organizing pneumonia post-COVID, one of the patients. And this is the CT, the person who has got ground glass opacity, and you can see interstitial thickening. And this patient is going into fibrosis now. So the question, and this is another CT of similar type, how to prevent and treat COVID fibrosis? And that is a question. Is it possible? Does corticosteroids help? Does antifibrotic drugs like nintedanib and pirfenidone help? Is there a role of physiotherapy or breathing exercise? This is what I'll be talking about. Now, what I do in my practice, and this is the same slide which I showed, what I do in my practice, and I'll be talking without slides now, that when the patients are discharged from the hospital with severe COVID, and they go home or on oxygen or without oxygen, usually they are discharged on corticosteroids. I am talking about severe COVID who are admitted in the hospital or in the ICU. The steroids are given in the dose of 0.5 milligram per kilogram body weight in the dosages of prednisolone dosages. We taper it over a period of 4 to 6 weeks and call them after a period of 3 to 4 weeks and do a CT scan. If the CT scan shows something like this kind of fibrosis, then we put them on either pirfenidone or nintedanib. We also do their C-reactive protein and D-dimer and ferritin. If the C-reactive protein is high, then we continue with corticosteroids. But concomitantly, we put them on pirfenidone. We start with 200 milligram 3 times a day and weekly escalate to the dose of 2400 milligram per day. And then gradually, as the pirfenidone, or we start with the nintedanib. Nintedanib is started in a dose of 150 milligram per day. And then if they are able to tolerate, then we increase the nintedanib to 150 milligram twice a day. How do we monitor them? We do their pulmonary function test. We do their 6-minute walk test. 6-minute walk test is the most important test for these patients. And if there is a desaturation of more than 3%, like if the person starts walking at the saturation of 94%, if the saturation drops to 86 or 87%, we know that his diffusion capacity is altered. We also do their PFT and look at their vital capacity and diffusion capacity. The further follow-up is done based on 6-minute walk test, pulmonary function test, their oxygen requirement, and their extent of breathlessness. We do not do CT scans very often because it is not possible to do and they don't actually guide us a lot. We never do CT scan on a monthly basis. Usually we do CT scan on every 2 months or after 6 weeks. That is also if necessary. Now there is no evidence till now that pirfenidone or nintedanib is actually beneficial in preventing pulmonary fibrosis or improving or reducing the decline in lung functions. But I always say that lack of evidence is not evidence to the contrary. Therefore, in this dreaded disease, if both the drugs have been helpful in treating pulmonary fibrosis to various diseases, there is no reason why they should not work in patients with COVID-related fibrosis. So far, we have an experience of about 6 to 8 months post-COVID. And what I want to share with you that majority of our patients who are disabled and go home on oxygen from 3 liters to 4 liters per day per minute, they are generally over a period of time improve. I do not know whether they improve with time as a natural healing, whether steroids help or whether the antifibrotic drugs help. But there is no doubt that the supportive therapy like regular exercises and breathing exercises, strengthening the respiratory muscles, certainly help in improving the better outcome. So far, there are no guidelines, international or otherwise, about using antifibrotic drugs for COVID fibrosis, but we all are using in the interest of the patients. So concluding my talk, all the three, idiopathic pulmonary fibrosis, scleroderma and COVID fibrosis, do require antifibrotic drug. It is a proven benefit in idiopathic pulmonary fibrosis. It's a standard of care. It has come into the guideline. In the scleroderma, it has been only one study has proven it, so we have started using it for all the fibrotic diseases. In COVID inflammation, we use it along with systemic steroids, and we believe that it helps in reducing the pulmonary fibrosis and improving the outcome. So I'm thankful to all the organizations which have, including ONGC and others, which have invited me, and I thank you, Dr. Sandeep, Dr. Angela Sharma, for introducing me and giving me this opportunity to present my thoughts. Thank you very much.
Thank you so much, sir, for your valuable time and a wonderful talk. We have a couple of questions for you in the Q&A box. If you could please open the Q&A box and scroll all the way down. The last two questions are for you, one being from Dr. Kulkarni. And
Yeah, I can read that. What is your opinion about noscapine, an old wonderful drug in COVID? Noscapine is a cough suppressant. So it is a cough suppressant. So I don't have any opinion. Neither of I have the experience. So I don't find any specific use of noscapine in the management of COVID. The second question is there a role of hyperbaric oxygen in post-COVID pulmonary fibrosis or pranayam? So I'll take it as second part first. Pranayam, I think, is useful. What pranayam does is that, it uses the respiratory muscles, and it is anecdotal, but I do advise to all my patients to do pranayam, or we ask them to use incentive spirometry. You must have seen that three balls, three colored balls, they have to try to lift with their inspiratory effort and keep it there for as long as they can. Hyperbaric oxygen does not have any role in management of post-COVID pulmonary fibrosis. To my mind, hyperbaric oxygen is used in high altitude pulmonary edema and also in some other condition like drowning. As far as COVID is concerned, the oxygenation is maintained by either by non-rebreathing mask or by high flow nasal cannula in the ICU. And also we use BiPAP, that is non-invasive ventilation. I am not aware of any use of hyperbaric oxygen in the use of COVID. The third question is breathing exercise, helpful yoga. Yes, to my mind, they are very useful and I do advise to them. But so far, there is no randomized trial to prove that yoga or breathing exercise lead to improve outcome. But as I said, lack of evidence is not evidence to contrary. So at least I do advise all my patients with COVID who are discharged or who are at home, especially those who have had pneumonia. I ask them to do yoga and pranayam and do breathing exercises. Thank you.
right, sir. Thank you once again for your time. And no doubt you have a very rich experience of 41 years. And the industry has really benefited from your experience, particularly at this COVID time.
Yeah, I know this might be a boring lecture as far as IPF is concerned, but anyway, that's okay. My pleasure to be here, and I'm there all the time. Anytime you want my opinion or my advice or my lecture or whatever, I'll be there all the time. Thank you so much, and thank you, Dr. Sandeep. Thank you.
Thank you, sir. Thank you very much.
Okay.
Right, so we continue with our scientific feast, and I would like to welcome our next speaker, Dr. Praveen Chandra. He's Chairman Interventional Cardiology Medicity. He's going to talk about stroke prevention therapies. Dr. Chandra is a leading Indian cardiologist and chairman of interventional cardiology at Medicity. He is recognized as one of the leaders in angioplasty in the country and is proficient in a lot of new devices and technologies. He has been awarded for success and achievement in the field of medicine with Padam Shri in 2016 by the President of India. He has also served as Director of Cardiac Cath Lab and Acute MI Services at Max Healthcare and Consultant Cardiologist at Escorts Heart Institute and Research Center, Delhi. He has published approximately 100 articles, reviews, and abstracts in various national and international journals. He has been awarded the prestigious Recognition Award for Success and Achievement in the field of angioplasty in India in 1998. So once again, I welcome Dr. Praveen Chandra Sir, the floor is all yours. Please take over.
Good evening to all of you, Dr. Anjula, Dr. Sandeep Sharma, and all my friends here from the Association of Occupational Health. And I'm glad that I'm here this evening to share with you some of the new information which has come up, which is very, very important. And I think it is good to share with you. So, can you see my screen?
Yeah, yes.
Yes? You can
Yes.
see my slides?
Yes, we can see, sir.
Okay. So, I'm going to talk to you about stroke prevention. And now, many people may think why a cardiologist is speaking about stroke prevention because it is a neurological thing, it's a neurology specialty. But let me tell you, heart and brain are connected so intensely. And now we have found the exact pathological connection between the heart and the brain. And we have found that a large number of patients who come with stroke are actually known as cardioembolic stroke, which means it is actually the heart which is the culprit, which is leading to the stroke. So, how do we treat this problem? How do we prevent this problem? Now, if you look at the stroke, I mean, so many strokes happen in India, in the entire world, and all these strokes can be divided into two basic categories. One is ischemic stroke, and the other is hemorrhagic stroke. For hemorrhagic stroke means the brain hemorrhage has happened, and the ischemic stroke means some clot or some embolus has gone in. And it has been found that 90% of these emboli which go to the brain actually come from the heart. So, who is the culprit? Heart is the culprit. So, we have to look at how to prevent these embolus to go out from the heart. So these embolic strokes could be because of some kind of a deposition of atheroma in the site at the arteries in the carotids, or sometimes it is nothing. All the arteries are okay, and we find that the heart is throwing these embolus into the brain and leading to large infarcts, which is, I'm sure everybody understands this, that stroke is one of the most devastating diseases for the person and for the family, because what it leads to, the patient still lives many times, but it lives with so much disability and deformity that they are hemiparetic, they are unable to walk, and 30% chances are they are not walking with assistance. Cognitive defects are in half of these patients. Depressive symptoms are bound to happen in these patients. About one fifth, every fifth patient is aphasic. They are almost half or one fourth of them are dependent on somebody in the family. So you can imagine what is the bad impact of this problem. Now, the recurrence of stroke can also happen. Once the stroke has happened, a second stroke can also happen. So we have to prevent the problem of stroke by finding out what is the cause of the stroke. So, of course, when stroke happens, it is an emergency situation, and now we have stroke units which can take care of these patients by our colleagues in the neurology, the neurointervention, and acute intervention is now possible. As we do for acute heart attack, acute brain stroke can also be treated. So then we go on how to prevent the stroke from the heart. Nothing should go into the brain, because so where does that clot go from? So PFO, patent foramen ovale, which is a hole in the heart which stays in the body for in about 45% of the people have cardioembolic stroke, 35% have PFO associated with that, which means patent foramen ovale. So this patent foramen ovale, if it is existing, and 10 to 14% of ischemic strokes occur in patients under age of 45. So in young person, if a stroke is happening, there is a 90% chance that it is because of the PFO or because of atrial fibrillation, recurrent atrial fibrillation. So these are the common causes of stroke in young, as you can see here. And this is also known as cryptogenic stroke, which means no reason for that and stroke has happened. But now we know the reason. So this is occult paroxysmal AF. You don't know that the patient has AF, but he actually has atrial fibrillation, and that is undetected, and these patients go on to develop stroke. Then patent foramen ovale, as I already told you, then thrombophilias, and then of course the last is aortic arch atheromas, for which we do not have any definitive treatment except treatment in the acute phase and also given statins and aspirin for the lifelong. So what happens? Here you can see that this is the clot which actually moves from the heart into the brain through the patent foramen ovale. A small clot can also lead to a big stroke. So these clots have to be stopped from going, and you can see here in the echo a large clot from the leg, which was because of a DVT, because patient had injury into the leg where a DVT was formed, and this clot moved from the leg into the heart, and now it is passing through the PFO and going into the brain very slowly, leading to a stroke. So what is the recommendation now? If somebody has this kind of a problem, how do we take forward? So there are a lot of studies which have been done, and they found that medicines are of no big use in these patients. Giving antiplatelets or anticoagulation is of no big use if somebody has a PFO. So PFO and many countries have given guidelines, and you can see the new guidelines which have come up in United States, Japan, Germany, and Canada. And all these guidelines have shown that in young patients, younger than 60 years with a PFO and who are appearing to have an infarct, there has to be a recommendation to detect what is the cause, whether it is a PFO or atrial fibrillation, and we have to treat these patients by doing a PFO closure. And how do we do the PFO closure? Do we need to do a surgery? The answer is no. We can do a PFA closure very easily, very easily these days by doing, and these are all the guidelines from Germany, from every country, that young patients who have this problem, cryptogenic stroke, PFO has to be closed if there is if the flow is happening from right to left. So these are the various countries, various associations guidelines about closure of patent foramen ovale in patients with embolic stroke. Now, this is the BMJ recommendation on the clinical practice guideline, again showing that PFO closure is the foremost technique of treating this problem, and antiplatelets and anticoagulation therapy alone may not be enough in these patients. So this is the final recommendation. It is strongly recommended over antiplatelet therapy in patients with cryptogenic stroke. So the treatment options are, how do we do it? This is the device which we use. It is a very soft, made of nitinol fiber mesh, which is taken inside the body, which is compacted and taken inside, and it is released under conscious patient is conscious sedation. Sometimes we give anesthesia, but most of the time conscious sedation. And this procedure takes about less than 40 minutes into skin, and the patient can be discharged on the same day. So you can imagine how easy it is to do, and the effectivity of this procedure is 99%. You can see here, this is how it looks. This is the device which is put inside the PFO through a small catheter, and the success of this device is 99%. Now, this is a patient, typical patient, young patient who comes with a stroke and undergoes investigation. We do a MRI. We find that there is a small ischemia, area of ischemia. Angiography is done in the brain. Nothing is there. So PFO is diagnosed and it is treated. So this is the treatment of known as PFO closure. Very effective, very easy, and must be recommended to these patients. The second problem I'm going to discuss with you today is the stroke reduction by treatment of atrial fibrillation. In patients of atrial fibrillation, which is the commonest arrhythmia for anybody above the age of 40 years or 50 years, very, very common in patients of heart disease, in patients of lung disease, in any acute illness, atrial fibrillation happens. And with advanced age, atrial fibrillation happens very commonly. So the connection, what is the connection of fibrillation and stroke? The most serious problem which atrial fibrillation gives is that it gives rise to stroke, because clot formation can happen inside the heart. You can see that this is a small clot which forms inside the left atrial appendage of the heart, and one fine day on its own, it will jump out and go into the brain and leading to a stroke. So the prevention of stroke in atrial fibrillation, the first step is to give medicines. Warfarin is the commonest medicine we give, and now we have newer medicines where we can give them, and they are known as NOACs. And these are the medicines you can see here, the rivaroxaban, dabigatran, apixaban, etc. But many times these patients cannot tolerate these medicines. There is a bleeding which happens. They cannot control the level of anticoagulation. So in these cases, we have to take the help of occlusion of left atrial appendage by some kind of a device, which I'm going to show you. Now, what you see here is that this is the risk scoring which we do in these patients. This is known as if the bleeding risk is high and the stroke risk is high, then these patients have to be taken for a left atrial appendage occlusion device, because these patients cannot be given medicines. If they are given medicines, they will bleed inside the body. And these are the typical patients where we check the risk of bleeding and the risk of stroke. And many of these studies have shown that the stroke risk, the major bleeding risk with allow is 2.6%, whereas if you don't do it, the risk of bleeding is much higher. So that is why we have to look at these medicines first. If they don't work, these are the limitations, because many times patients are not taking these medicines. And the LAO procedure, if it is done, they don't have to take any medicines after 45 days of implantation. So the medicines do have a role, but certainly these are the barriers to these new medicines. And of course, confusion is still there about the how long you have to give these medicines, and when the bleeding happens, what to do. So in a patient who has this kind of a problem, what we do is we plan to take up these patients for a LAO closure device. And once the patient is stabilized, then we consider LAO a procedure in these patients. Once they are completely out of the ICU, they are into the wards, then we take them up. And these patients generally have atrial fibrillation, either paroxysmal or permanent. And once we identify this problem, we do a transesophageal echo test. On echo, we identify if there is no clot inside, these patients are taken up for LAO procedure. So this is the usual indication for LAO procedure. Patients with previous major bleeding, high bleeding risk, angioplasty and stenting has been done. The patient is not tolerating warfarin or has a stroke on warfarin and has renal or hepatic disease, again with labile INRs, then these patients are to be taken for a LAO procedure. So how do we do it? Here, what happens is that this is the left atrial appendage inside the heart. From here, the clot goes down into the ventricle and then goes out into the brain through the normal circulation. So this is what we are going to do, is that we are closing this appendage where the clot forms by doing a procedure known as the left atrial appendage occlusion, where we put this small disc inside or umbrella. And surgery is only done if it is being done for some other procedure. Otherwise, doing surgery becomes too much for these patients. So we do it without surgery. And these are the various kind of plugs which we use for doing the left atrial appendage occlusion for prevention of stroke in patients with known atrial fibrillation. Again, it is a catheter-based device. We go from the femoral vein and put this device inside the left atrial appendage. It is permanently there inside. The procedure takes about 1 hour, and the hospital stay is about 1 to 2 days at the most. And generally, these patients are done under either sedation or general anesthesia for a very short time. After the procedure is done, we do an echo test, everything is okay. Then these patients are put on small dose of anticoagulation for 45 days. And after that, they don't need to take any anticoagulation. So these are the various studies which have been done to show whether this technique is better than giving medicines or not. And they showed that there is a definite benefit of doing this procedure, and has been found to be almost as good or even better than warfarin when we take in patients who are having atrial fibrillation. So these are the other studies, or many studies which have been shown to be safe and effective to use this kind of therapy. Now, this is the Implanzer device therapy, which has been studied and showed that in patients of 70 years, 70 to 80 years, and more than 80 years, all can be taken up safely for this kind of procedure, and it reduces the risk of stroke in all this subgroup of patients. And the best effect was seen as the age advances. So if it is 70 to 80, 57% reduction, and if it is more than 80 years, 85% reduction in stroke. So generally people think that if the age is more, you may not do this therapy. Actually, it is the reverse. You have to do this therapy even if the age is advanced, because you want to prevent stroke in these patients. And this procedure is very, very safe to be done in these patients. You can see the bleeding rate goes down dramatically when we do this thing. So atrial fibrillation, which is the commonest cardiac arrhythmia and the biggest problem with them is stroke, can now be prevented by doing this kind of therapy. In many patients, even where we have done a transcatheter valve replacement, in these, this is one of my patients where we have done the TAVR procedure.
Then on endoscopy,
you can
there
see
were feeble bleeds were found on stomach, so they were clipped. Almost 9 clips were required for this. And then once stabilized, we have decided that what is to be done for the future. So multiple scores were calculated. When we calculated STS score and Euro score, both were coming above 6.5. So she was in intermediate risk for aortic stenosis. But in terms of AF, Hasbled score came out to be 7 and Chad's best score came out to be 8. So she is very high risk for CVA and very high risk for bleeding. And on anticoagulation, she had bleeds and anemia. So she is not a good candidate for anticoagulation. So she requires both treatment for severe aortic stenosis and for this AF with risk of bleeding and risk of embolism. So first she was planned for stabilization. After stabilization, we have planned for a TAVR in her case, and she underwent TAVR on 6th of this month and recovered very well.
Just
that was
about 10 days back.
8 days back. And that was done under local anesthesia, and she recovered within 1 day without any complications. And now after 8 days, we are planning for L appendage closure for prevention of future embolic events.
So you can see that here we are doing the valve implantation without surgery in this patient because it's a patient and she
For this
underwent
procedure,
this
it is
procedure
very
very well.
important to look at several different anatomic.
So this is the echo. I just am skipping the slide, and this is how you can see that we are taking a small umbrella inside, and this umbrella is being released here. This umbrella is being released here inside the heart, and the patient is under conscious sedation. She is absolutely okay. And then after 1 day, she was discharged, and you can see that this closes the LA appendage, and that's how we finish this
Looks
procedure.
okay.
You
There's
see
no
this?
leak anywhere.
Yeah, there's no leak at all.
And the
Complete seal is done, and now once the procedure is done, we take out the whole thing.
So we are done. Now we are removing the sheath.
So this is a live procedure which we have recorded. I'm showing it to you just for your reference. And we are taking out the sheath through which we have done this procedure.
very well seated.
You can
Good
see that the
compression.
device is seen. So finally, I must finish this presentation by saying just simple 2 things, that PFO closure is a safe and effective strategy for prevention of stroke, and left atrial appendage occlusion, which is known as LAO, is a safe and effective procedure for prevention of stroke in patients of atrial fibrillation. And that is how this new therapy has started and is being done very effectively in patients who are coming with early or young stroke. Thank you very much for your kind attention, and maybe we can have some questions or discussion.
Thank you so much, sir, for the wonderful presentation. Really appreciate. There is a question for you in the Q&A box. If you can please open and scroll all the way down. So the last question is for you, please.
Yeah, sorry to ask about heart. Have you heard of treatment by Madhav? What is that? I don't understand this question. And they can treat heart disease. What is this question? Who has asked this question? Can he just clarify this? Madhav Bag, what is that?
I think he pumps in a lot of saline to wash out the toxins, but I would see if I can get Dr. Damodar to speak.
Okay. So I understand what he's saying. Actually, this therapy is an unproven therapy. If he's talking of chelation therapy, it is totally unproven and it has not been shown to be effective. And that is why I strongly recommend that patients should not be advised this therapy at all unless until there is nothing. if I say that angioplasty cannot be done and bypass cannot be done and medicines are not able to help in that situation, you can try whatever you want. But otherwise, this is not the choice of therapy. Please do not misunderstand this, because many times I have seen patients are advised angioplasty or bypass and they go get these kind of things done, and one day they land into a serious problem.
Right, sir. Any particular advice of or suggestion at the COVID time that we can follow?
So I must say that for prevention of stroke, the most easiest thing to do is regular physical activity, drink lots of water. Hydration is the most important thing, which we should do. Keep moving, and that helps in preventing stroke in many people, especially in elderly people, especially in people who are kind of more sedentary. In these people, everybody should try to do this. Sitting on the chair can lead to more occurrence of stroke. Relevant in primary prophylaxis of stroke in amine, diabetic or hypertensive patients, sir? I think this is a very good question. Somebody has asked whether aspirin should be as a general therapy. The most important thing is to control the diabetes and high blood pressure. Aspirin is only given in those people where there is evidence of atherosclerosis, which means that they have something in the CT angio or the angio or previous history of stroke or previous history of TIA. Only then, because the risk of bleeding with aspirin is also there. So, lead us to give aspirin for so many people just without any indication. Okay.
Thank you so much for your response. Really appreciate. You are right that stroke is really on the rise, and I have stayed in London for about 10 years. And every 3 to 4 hours, there was a public message on the national TV where they would tell people how to identify stroke and how soon they must reach to the hospital. So, really appreciate that you have picked up this topic. Thank you so much. Do we have any more questions or any question from the panelists, please? I think the
Dr. Sandeep?
absorbed and everybody was so engrossed and they have really enjoyed.
Actually, it was really a very important topic, and moreover, listening the topic from a cardiologist, intervention cardiologist, especially, that was a great thing, and the relation which you have which you have quoted and referred between heart and the brain, that is more important. So. Everyone has to be very careful regarding the stroke, and yes, if prevention is definitely better than the treatment, and we as occupational physicians, we also believe in prevention, and we are all working for preventing the disease. So because once a stroke occurs, although you may resolve the acute stage of the stroke, but later on patient may have some residual neurological deficit or some paralysis or some dysfunctional life will be there. So that becomes a problem for the patient and also for the family also, because it affects the relations between the family members also. So it do have a long term effect, both physical and psychological, and the social effects also. So we should be careful, and yes, as you have told, that wherever the things are there, some physical abnormality is there, it is detected either on echocardiography or some other investigation, then it should be promptly treated, because it may lead to some stroke problem. And as Dr. Angela said, in Western countries, definitely people are very cautious about all these diseases. But in India, we as an association, we would also like to propagate this particular learning from you, sir. Thank you very much.
Thank you. I can see Dr. Rajneesh Malhotra is already here with
Yeah.
his teachings and educational activities. So, Rajneesh, good evening,
Hi, good
and
evening, boss.
good to see you again here.
Yeah.
I'm sure he's going to tell us a lot about new things about cardiac surgery. So, welcome, and I'm signing off. Thank you very much.
Yeah, thank you, Dr. Praveen. And we'll be soon having a special session for both of you sometime in near future as the things are opening up. Uh, for last 1 year, we have been meeting on Zoom, and we have Dr. Praveen and Dr. Rajneesh for information. Every week, we used to conduct one webinar for our friends across the globe, across India, and we have conducted about 45 CMEs on webinar, and they are all available on our AUSD DigiConnect webinar YouTube platform. And especially for last 3 months, we have been conducting monthly occupational health briefings by Dr. Rajiv Kumar Jain, who is our senior vice president. So we are all well connected. We have not left any of our colleague in isolation. And as the things are opening up, we'll definitely meet and physically have a session with you. So thank
Sure.
you very much.
Thank you.
Thank you.
Reach to another yet very interesting topic. And before we start, I take the privilege of welcoming Dr. Rajneesh Malhotra. Dr. Rajneesh is Chief Cardiothoracic and Vascular Surgery, Max Super Specialty Hospital, Max. Saket. He'll be talking about incidence and treatment options for degenerative aortic valve disease. Dr. Rajneesh Malhotra is the Chief of Cardiac Surgery at Max Super Specialty Hospital. He's an expert in minimal invasive cardiac surgery, minimal invasive mitral valve replacement and repairs, coronary artery bypass grafting, aortic valve replacement and repair, atrial septal defects, and robotic cardiac surgery. Dr. Malhotra has done his education, MBBS and MS General Surgery from King's Medical College, Lucknow, MCH Cardiothoracic Surgery from Lakshmipat Singhania Institute of Cardiology, Kanpur, Fellowship in Cardiac Surgery from Department of Thoracic and Cardiovascular Surgery Hospital, Sweden. He has a rich experience of 25 years. He has been director at Medanta, senior consultant at Escorts, and chief consultant at Colombo, Sri Lanka. So I take the privilege of inviting Dr. Rajneesh Malhotra. So over to you.
Yeah, thank you very much. At the outset, I would like to thank Edwards and Association for giving me this opportunity to be present here today. And as you have just explained, thank you for Dr. Angela for introducing me. So I have been in cardiac surgery for almost 30 years now. Dr. Praveen Chandra happens to be 1 year senior to me from the same college. We were both, like 1 year senior, junior. And so he, joined cardiology and I was in cardiac surgery. And we know each other for a very, very long period. So almost, I would say, more than 30, 35 years we know each other. And we were together as colleagues in Escorts and Vedanta. And then I moved to Max, and then he was in Vedanta. So today evening, I'll be talking to you about aortic valve disease. I think something which, I would say all of us have understood over a period of time that, a lot of changes and a lot of things have happened in aortic valve disease per se. We have started, looking at the aortic valve disease in a different perspective. We have started doing aortic valve disease in a different manner. So what is the incidence, how we are going to tackle this, and how we are tackling this in today's date and time in 2021. So for next 20 minutes or so, I will be just talking to you about this. I'll be sharing my screen, I think, if I am being allowed to do that.
Yes, please.
Are you able to see my screen?
Yeah, yes, sir, yes.
Can you see my screen?
Yes, sir.
Okay, thank you. So I will be talking to you about the aortic valve disease, as I said. So as I said, I have seen cardiac surgery developing in front of me, and the way we were doing cardiac surgery, the way we started practicing cardiac surgery some 35 years back. I did my MCH in 1991, 92, and now today in 2021, most of the things I would say have changed, and we are not doing the surgery the way we were being taught. I will say, Dr. Chandra took you through the cardiology developments. Similarly, the cardiac surgeons, have been changing and have been doing different things. And have been practicing cardiac surgery differently. I am at Max Hospital, Saket, as most of you would be knowing. This is in South Delhi, and I am heading cardiac surgery over here. And as you must have been, going through and must be knowing, very familiar with this picture. He's our Prime Minister, and he has been showing us Achhe Din, and which many of us are waiting, or few of us feel that we have had it. But we as cardiac surgeons, I would say, really had a dream run for 3 decades. We started cardiac surgery in 70s. Cardiac surgery took a regular shape, or I would say in a formal this thing. So in 70s, 80s, 90s, cardiac surgeons had a dream run, and the cardiac surgeons were treated as demigods. But as you say, in 3 decades time, when the stents and were being invented, when the cardiology started doing the ballooning and stenting, and then the drug-eluting stents came, and then most of the meetings, the cardiologists, even Dr. Chandra, Dr. Seth, and everybody started saying that the days of cardiac surgeons are over. The cardiac surgery is going to change. The cardiac surgeons are going to become extinct. And cardiac surgery became, I would say, it came at the crossroads. It saw within 30 years of time the best of the times, and it started seeing the worst of the times. And I would say in 1999, 2000, or late 2000, when they started, showing that the drug-eluting stents can be put in all the vessels, so they will not be requiring any bypass surgery. And then the TAVI came. Then they said they will be putting TAVI in every patient, and then the aortic valve surgery will not be required. So, but that has not been the case. I am still doing the cardiac surgery. I'm still doing the aortic valve replacements. But the only thing which has happened, or which has changed over a period of time, that I'm doing much more complex surgeries. And whatever changes, the cardiologists did, they made us think that what lies ahead. So what is the future of cardiac surgery? So how we are going to take cardiac surgery forward? So they made us change our ways. In bypass surgery, we started doing surgery on a beating heart. We started doing minimal invasive cardiac surgery. We started doing surgery with the small incisions through small thoracotomy. We started doing more and more arterial grafts. So, in a way, I would say that the cardiologists challenged us with newer techniques and angioplasty and stenting, and we as cardiac surgeons took the challenge, took the bull by the horns, and then we changed it and changed the ways we have been doing cardiac surgery. And similarly, I would say for the coronary surgery, it happened. Similarly, for the valve surgery, in 2021, we are doing minimal invasive surgery, which has become a standard of care. So anybody who requires a mitral valve replacement or an aortic valve replacement, I do cardiac surgery with a minimal incision. So I need not open the sternum, or I'll just do the valve replacement with partial sternotomy, or with a small thoracotomy. With a 5 centimeter incision, I can change the mitral valve, aortic valve, and close the ASDs, close the myxomas, do anything. And so, so minimal invasive surgery has become a standard of care. So we, instead of cutting open the sternum, so you can cut the sternum partially up to this place. You can cut the sternum transversely, do the mini sternotomy, and do the valve replacement, do mini thoracotomy. And if we are talking about aortic valve, so we have been in the aortic valve doing upper partial sternotomy, doing right anterior thoracotomy, and through the different small incisions, we have been doing aortic valve replacement. And similarly, we have been putting TAVI, is a transcatheter valve, which is being implanted as we put through the groin as we do the angiography. That is being done by the cardiologist. Dr. Chandra does it. Many surgeons do it, and we do it in our patients. So we also change the way we are doing the valve surgery. Now, as I said, all the surgeries can be done through the minimal invasive. So the aortic valve replacement, mitral valve, ASDs, LA myxomas, LA tumors, tricuspid repairs, right atrial and bypass surgery, all can be incisions. And the advantage is obvious. The mean hospital stay is 10 hours. The hospital stay decreases, the ICU stay decreases, the mortality is not even 1% in these patients. So, and it has got a good cosmetic advantage. In a female patient, the incision goes under the right breast, so which is not visible. And for the aortic valve, the incision is in the second intercostal space, small 4 to 5 centimeter incision. It gives us a good cosmetic advantage. This is an aortic valve replacement, another patient with aortic valve replacement. So the things have changed, things have evolved. But the problem stays when we are talking about the incidence and the problems in India. So there is estimated 3.5 million patients in India require treatment for the valvular heart disease, because incidence of the rheumatic heart disease has decreased, but it has not gone, and it is still remains a major factor for our patients. 96% of the patient valvular disease are still rheumatic, although the patients are, we are operating elderly patients, so degenerative disease is also coming. So when we have the degenerative disease, the patients are living for a longer period. So when the patients are living for a longer period, so we have degenerative aortic valve disease, and the incidence of degenerative aortic valve disease or degenerative aortic stenosis is almost 5%, where we may require to do some intervention in aortic valve in degenerative aortic disease. So this is the prevalence of aortic valve rheumatic fever in India. And as I said, as the people are living for a longer period, and the degenerative aortic valve disease is increasing, and we are operating more and more elderly patient who are 70 years, 60, late 60, early 80, and patients beyond 80 also, if they have comorbidities, then we are planning for transcatheter valve or TAVI. So the patient who are symptomatic and have this disease, so we are treating these patients. So the medical options are increasing. So we have medical management and prophylaxis. So the spectrum has changed. So we have very effective medical treatment. And once the medical treatment is now more effective, then we can do balloon valvotomy if it is a mitral valve. An aortic valve, if it is a situation where it's a salvage procedure, we can do aortic valvotomy if it is required. Otherwise, we can do a aortic valve replacement, repair, as the things would be indicated. And the valve repair, generally not done for the aortic valve, for the mitral valve, that remains the main cornerstone of treatment. Whenever it is possible, we want to preserve the valve, we want to save the patient valve, and then do the repair. And if it is not repairable, then we do replacement of the valve. Valve replacement is a very simple procedure. Per se, if we are talking as a surgeon, it's a fairly standardized procedure, and it has got very well practice protocols. And the options for us for the valve is either we use a mechanical valve or a tissue valve or transcatheter valve when we are talking about the aortic position. But if we talk to a physician or a person, but there is which valve to choose. It really gives a headache. The people are very confused at which valve and what we should be doing, which valve should be required for a certain amount, certain age of patient. So if, these are the mechanical valves, if you are looking at it, these are the tissue valves, and this is a transcatheter valve, which we put through the groin, through the angiography. So these are the choices are many. And if we have to, and so I'll just take you through how we choose it and which valves we should be, choosing for our patients. And whenever, as I said, the repair is possible in mechanical, in the mitral position, we are repairing. The incidence of repair and the tissue valve is increasing in India. And that is more and more tissue valves are being put, because as we understand in the mechanical valves, whenever we give mechanical valves, the patient has, where I would say has to take anticoagulation throughout the life, and you have to manage the PT-INR, which becomes a big problem for the patients. So so that remains a challenge, and thromboembolic complication with the mechanical valves are very high. So so incidence, as I would say, the few years back, the tissue valves were only 4% in 2000. In 2021, it is around 35% of our patients. We are, doing valve replacement with tissue valves. So, so more and more tissue valves are there. So the first generation tissue valves we used to have, so there we have, the life of these valves was less. This life of was 5 to 7 years, 10 years, but now we have got very good quality valves, which I'm just going to take you through, which give us a uh, good solid 20 years and give us more for our patients. And as I said, in the mechanical valves, you have to maintain anticoagulation, you have to titrate the PT-INR, you have to regulate the dose of warfarin and acetrom, and regulate, and that becomes a big challenge for the patients. And the only problem with the tissue valve here, we give anticoagulation only for 3 months. After that, we stop it. But the problem remains that after 3 months, the valve life, if it is, the first generation, it was 5 to 10 years, and now, as I said, the valves are, we are having valves of newer generation, which are, good for going to last for 20 years or more. So these are the basically valves. If we are, looking at this, is the mechanical valves, biological valves, and then the transcatheter valves you can put through any artery. Basically, we can put through the femoral artery, we can put through the apex of the heart, we can put through the carotid, through the subclavian, directly we can put, and then we have sutureless valves, which we can put without putting sutures, which saves a lot of time for our patients. So these are the types of the mechanical valves. This was a Star Edward ball and cage, which is not being used now. These are the mechanical, and these are the tissue valves, different types of the tissue valves. So there is nothing, I would say the ideal situation would be that we have one valve for life. But unfortunately, this is not the situation. So we have to tailor treatment according to the patient requirement and patient age, and then do the treatment accordingly. So one valve for life would have been the ideal thing, but it is not there. So this is pretty complex thing, for you to understand. But I would say, if we have a patient who is around 50 years or below 50 years of the age, we choose a mechanical valve. If the patient has got 50 years and above, we give them option of tissue valves. And whenever the valve is repairable, especially in a mitral position, we repair the valve. Otherwise, we try to replace the valve. Cost of the procedure remains a big challenge. And these are the basic, many companies which are there, which, there are certain Indian companies as well as the international players. We have in the valves. And this is, as I said, in a mechanical valve, a thromboembolic complication is a major challenge what we face. So hemorrhage is another problem which occurs in these patients, because these patients are on anticoagulation, on warfarin and acetrom, and these mechanical valves have not changed much. But the only thing they have started doing, that they have started giving PT-INR machines so that we can regulate the PT-INR for in such patients. And many patients, they have got very small aortic root, small annulus, so it becomes very, very difficult thing for surgeons to replace these valves. And then the only thing you have to do, because this is how we look at the aortic valve. Many times we find the valves which are so calcified, and it looks really horrible when you have this look. So this calcified annulus, you have to take out the calcium and make it bigger. And if we have and enlarge the annulus to put a good size valve. And so now, we have got lots and lots of, I would say, biological valves. These are the first generation valves which were available, which were good for, I would say, 5 years. Now, these were the valves which were good for 10 to 15 years, and now we have valves which are good for 20 years. So if in a patient who is around 50 years, you put a biological valve which is good for 20 years, and that valve remains good for 20 years. After that, you can do a valve in valve, you can do a TAVI, and the patient has from 50 years onwards for another 30, 40 years, you've got a tissue valve without taking anticoagulation, without any problem of anticoagulation. So this is the 4th generation tissue valve. So these valves are made of bovine pericardium, and this pericardium is molded, and then you get they have the leaflets made of the bovine pericardium, and this is gives us a very good durability. This valve, which I just showed you, is good for 15 years, and then there is very less wear and tear in these valves, and we have got I would say long-term data available to us for 15 years, for 20 years, gives us very good hemodynamics, which is as good as the normal valves what we see in our own healthy individuals. So excellent hemodynamics with these valves. And now with Edwards has just launched this valve last year in India, which we call as Resilia tissue valve. Because so far, whenever we were having these valves, we were preserving this in glutaraldehyde. And with glutaraldehyde, it was happening that the valves would attract calcium. And the valves, as I just showed you, would attract calcium, and the calcium, the valve size will become small, and the valve will start degeneration. So this Inspiris Resilia aortic valve is the latest launch, and which is, I would say, a revolution in cardiac surgery, which has got future thinking that if we have to do a TAVI in future, this valve is ready for TAVI, and this valve itself gives you a good unparalleled 20 years of healthy life. So it is a proven design of a bovine pericardium, which the Edwards have been providing and in the previous valves. So it is the same thing. What happens in patients who are younger? The valves start degenerating early, because younger patient, if you look at the 50 years, the probability of reoperation is very high in these patients. And elderly patients have got very low probability of reoperation. But if we put this Resilia valve or this Inspiris Resilia valve, so the probability of reoperation in younger patient also decreases significantly. So what they do, as I said, they take out the glutaraldehyde sites where the calcium does not bind, and they replace it with glycerine. So they do glycerolization, and with glycerolization, so these valves, the calcium does not attach to these sites, and the valve does not become stenotic or do not degenerate and remain good for 20 years. And these valves come to us in a dry state. Otherwise, all the tissue valves are preserved in glutaraldehyde and in water. This comes in a vacuum thing, or this comes in a dry state where we can straight away take it from on this and put it on the table and do that. And these are the sites which are being covered. So this is how it happens. They take out the site, do the glycerolization, the water disappears, and no calcium gets attached to this site. So this is a regular valve on the right side and left side. So this is how the valve leaflets start degenerating. Here the valve leaflet do not degenerate. And as I said, so you can put these valves in younger patients. And in future, if these valves require any kind of valve replacement these patients require, so you can do valve in valve. You can do a transcatheter with valve without opening this. So they call it as VFit technology, means that this valve is already future ready. So if you require a TAVI in future, so this has already been thought, because there is a sliding mechanism. So you can slide the valve, make the stent bigger, and fit the valve within this valve with this VFit technology. So that really gives a bigger size valve. Even in an elderly patient who is like 70, 80 years of age, you can put a valve within valve and again give a free, I would say, a free life to the patient without any requirement of anticoagulation. And these are the sutureless valves. The concept started in 1960s. So these are the sutureless valves which we put where we don't need to put any sutures, which saves a lot of time for surgically. So you just open the aorta and take out the valve, as very much like the TAVI valve. You collapse the valve, you open the aorta, take out the valve, and just implant the valve and come out. And with this help of this stent, the valve stays in its place. So this is exactly what happens. It is a sutureless valve. So you excise the valve and put the new valve, and you are ready. So this saves a lot of time while we are operating. You have just taken out the valve, put a new valve there, implanted, and just come out and close the aorta. So it saves lots and lots of time. No suturing is there, and gives very good hemodynamics to our patient. The stents are elastic, and you can put this, and you can put it in, and a bigger size valve can be put because there is no sutures there. And you can do through mini sternotomy, through mini thoracotomy, and you save a lot of time. And there are a lot of papers there which have been put for the sutureless and or the newer generation valve, which tell us that there is no structural valve deterioration. The valves do not get damaged over a period of say 15 to 20 years, and which gives a very good hemodynamics as well at the same time. So as I would say, in aortic valve, low risk and medium risk patient who require aortic valve replacement, now these newer generation valves can be put, sutureless valve can be put. As of now in India, TAVI is still reserved for the patient who are very high risk or have got multiple comorbidities. In those patients, we do TAVI or transcatheter valve replacement without, I would say, opening the sternum or just through the groin. And as I had mentioned earlier, we can put it through the femoral artery, through the apex, through the aorta, through carotid, through subclavian, through any position. You have to just cross the aortic valve and place the valve. This is a valve which we call it as our transcatheter valve, and it has also been there for quite some time. And we are putting it at Max. They are putting it at Medanta as well as at Escort. So there are certain sites which we are doing transcatheter valve also. So to end the talk, I will say minimal invasive surgery has become standard of care. Surgical anatomy pathology, one valve fits all is not the approach. It does not work that way. So we have to tailor the treatment according to the patient requirement. Present generation tissue valves are improving. The durability and hemodynamics have improved. Sutureless and rapid deployment valves are there, which are time tested, and TAVI and are reserved still for the high risk patients and intermediate risk patients. Thank you very much for your attention. So if there are any questions, I'll be more than happy to take if there are any.
I think it was a wonderful talk, and we all absorbed whatever you said. So I request any questions from the panelists, please.
Yes, Dr. Malhotra, it was a really nice talk. And my question is, at present, the cost of TAVI is very high. It is approximately 13 lakhs. And in India, the people having or which require this procedure is increasing. So according to you and your experience, how much time it will take that it will be within the reach so that more and more people are benefited by this procedure?
So, sir, in India as well, we have got an Indian TAVI, which we are doing in many patients. So that Indian TAVI is almost 50% of the cost of the American TAVI, you can say. So the American valve cost around 25 to 30 lakhs. So Indian cost around 12 lakhs. And then the implantation, total cost come to something around 15 lakhs. And as more and more valves will be implanted, the cost will come down. The research is happening, so more companies are making it. So we are expecting that is going to come down to close to 10. But I would say, at the other hand, we have got very good surgical tissue valves, which we can implant through the minimal invasive ways, as I just showed you. And those valves and the surgery cost is, I would say 1/6 the cost of the TAVI. So we can, with the good tissue valves, we can do, within 4 to 5 lakh rupees, a good surgical valve replacement with minimal invasive way. And even if we are using the latest generation, our 20 years good TAVI, which is Resilia, which I just showed you, which the valve cost 4 lakh rupees, another 3 lakhs for the surgical cost. So 7 lakhs, 6 lakhs. So you are getting a valve which is going to work for 20 years. So things are changing, and you can do a minimal invasive. So you're not opening the sternum from the side, you do the surgery. So which is, I would say, equally good. So TAVI cost will further come down in time to come, but till we say that it is going to come down below 10 lakhs or is in the reach of common man within 5 lakhs or so, we have surgical options, so which are very, very affordable. And again, you don't need to open the sternum, do this, and minimal invasive approach, it can be very easily done.
That's good, because in last 1.5 months we have referred 3 people which have been recommended for TAVI, and as you are saying that the people are having other options also, but whenever we try to find out those rates, they are not available. So we are forced. In medical sciences, everybody wants the best, and other options are not told to the patient, and they don't have any option but go for the best.
I would say, sir, you send it to us. That is what I can say.
Yeah, you can help me. You can at least we can have some other options also, because if only one option is there, we don't have anything, but we have to forward it.
I fully agree with you, sir. I fully agree. But as I showed you the minimal invasive way, I mean, this is.
It was really, I like this because it's a concern with me. So it was really a knowledge enhancing experience for me. And thank you. It's really very good.
And even as you said, sir, we use the best valve which is available, which costs around 4 lakh rupees. Plus the cost of the surgery, say another 2.5, 3 lakhs.
But so no one gives that detail of 4 lakh surgery. Everybody gives an estimate of 12.8 lakhs.
No, sir. I am sending you. You just send it to me.
Okay. Next time we'll contact you.
Okay, sir.
Yeah. Thank you. Do we have any other question for Dr. Rajneesh Malhotra, please?
Dr. Angela?
Yes, sir.
Dr. Rajneesh, first of all, I mean, a very...
Yes, sir. Yes, sir.
Of the topic. Then a little small remarks on the point raised by Dr. S.P. Chaudhary. We in Railways, sir, I work in Railways. I am chief consultant with the Indian Railway. We in the Railway, the cost is not that important. It is only the paper modalities which we have to complete, and we can very well take care of this treatment even within the cost of. How many centers in India are performing this surgery?
So TAVI surgery, you are saying, or the minimal invasive?
Yes, sir. Yes, sir. TAVI.
So TAVI, I mean, these days, I would say, if we are been saying in Delhi, there are 5 centers in Delhi, and in Bombay, 5-6 centers, two centers in Jaipur. So, I mean, not many centers. If we overall look at it, so it may be some 20 to 30 centers all across India who are performing. Because for that, you have to have some training. Your, I mean, cardiologists, your cardiac surgeons, your staff, everybody has to be trained. It's not that, I mean, you just have the technology. So everybody should be trained to do this with safety without any problem. So at max, I would say all across India, if we count, so there will be 25 to 30 centers doing it.
Okay, right, sir. Thank you.
Sir.
Right. So any last question, or should we thank Dr. Rajneesh Malhotra for his valuable time and a very wonderful presentation? I think it was very well absorbed. Thank you so much, sir, once again for your time. And I would now like to request Dr. Ashish Vijay Jain, Vice President of AEOHD, to please come in and conclude today's session. Dr.
Thank you very much, Dr. Angela. Thanks, everyone.
Thank you, sir.
Thanks a lot, Dr. Angela. And I should say that it has been a wonderful academic feast. The amount, the richness of the experience has been really unique. Each speaker brought in not only the experience, but a huge amount of insights from their own respective fields. I'm sure that each of us has been enriched and has immensely benefited out of how we can be managing things much more better at workplaces. Given the COVID scenario, today has been the day one. We are coming to an end of the day one. Tomorrow, we are going to have another session about how industries have been really putting up their practices to manage COVID at workplaces. So I would also like to invite all of you for tomorrow's session, which is going to be face-to-face, considering the COVID norms and the applicable conditions. We would be having both virtual as well as a face-to-face conference tomorrow. So thanks a lot for being with us today. And I'm looking forward to have most of you out there with us for the tomorrow's conference. Thank you so much.
Thank you.
Thank you, everyone. And sir, we all will meet tomorrow at about 9:30. So that we will start the session by 10 o'clock with the third Delhi branch oration by Dr. Rajiv Kumar Jain sir.
Absolutely.
And, everything is in order, and today's function was quite good. Dr. Shirniket and other of all executive committee members and all office bearers, they should be there. We have already sent the this personal invites to everyone to be physically present, and chief guest has been lined up. Dr. Pawan will be responsible for his things for coming, and Dr. Pawan, it's everything is in order, na?